So good evening everyone. My name is Dr. Daivik Shetty. I am your orthopedic and PMR subject matter expert at Manipal Medace, and the session that we are conducting today is the INI-CET Prepathon Orthopaedics. So what we're trying to cover in this whole session is to let you know the high yield topics in orthopedics and also to give you previous year topics, not previous year questions, previous year topic based questions. So the idea, the whole objective of the session is so that you can revise better and smarter so that you can rank better. So let's begin the session. Okay, so let's begin this INI-CET Prepathon session. Before we go into all of the question and answer sessions, I'll have a few things that I want to convey to you. The first thing is about how many questions can you expect from orthopedics in the INI-CET exam. Good evening, Mega. So first let's discuss how many questions have been asked previously, and then we'll get a rough estimate as to how many questions can be asked. So I've gone through a lot of papers of the previous year INI-CET exam. So this was the May 2023 paper in which there were 8 questions asked. 6 were pure orthopedic questions and 2 were integrated questions, one from anatomy and ortho, one from anatomy, one from orthopedics and radiology. Then if you look back to November of 2022, here there were 2 sessions conducted, and in both sessions approximately 7 orthopedic questions were asked, and previous year to that, May of 2022, there were 6 questions asked. Then again November there were 8 questions asked, and again going back to June where they had asked 6 questions. So roughly, if you have to look at the whole span, roughly you can expect at least 7 questions to come from orthopedics. Few of them can be even integrated. Okay, so we can expect 7 questions. Now let's look at what are the questions that are asked, and this is important because I have something I have to tell you, and I want you to understand how do you have to revise smarter. Why am I emphasizing on the word smarter? Because if you look at all of the topics that have been asked, so look at this is from May 23. I have data almost all till June 2020. So if you look at all of these topics that are asked, a pattern that emerges is that every year the INI-CET examiner loves to ask questions from a certain topic. Although the questions might change, he might dig deeper into the topic or it might become more comprehensive, but he loves to ask questions from a certain topic. If you look at osteoporosis, if you look at giant cell tumor, these are questions that are repeatedly asked in every INI-CET exam. So now the question is, how can you revise smarter? So to revise smarter, what you have to do is, instead of superficially going through the whole orthopedic syllabus, which is going to take you a lot of time, what you can do is you can go through these topics in a more comprehensive fashion. You can dig deeper into these topics, study them a little more in detail, because these are going to be rewarding. They are going to get you good marks in your INI-CET exam. So this was about how you should study smarter, and what I have done in my session also is included these high yield topics where we'll discuss in detail about each of these topics with the help of few framed questions. Okay, then coming to what I'll be including in this session, I'll essentially be having 3 segments in this session. The first two segments will be mainly high yield topics and previous year topics. I've mixed both of them together. We'll have high yield and previous year topics mixed together. Mind you, I'm not going to include all previous year questions, but I'll frame them in a different way and present you these previous year topics and high yield topics. At the end of the session, I've done something interesting, is I've put my neck on the line and I've tried to guess what questions might end up coming in your next INI-CET exam. And this is not just a random guess. What I've done is I've examined the pattern of the examination. I've also looked into what are the topics that are trending right now, and also dug a little deeper into our popular high yield topics. And I framed this few questions that might end up coming in your INI-CET exam. I've titled it as exam leaks. Okay, that will be at the end of the session. So let's start with our session. And before we start the session, I have an advice for everyone who's going to be attempting this question. So this session, I'll essentially be putting forward questions to you and you'll have to answer them. Hello, Aishwarya. So I'll be putting forward questions to all of you and you have to answer them. So my advice to you on the day of the INI-CET exam and also today when you're attempting the question is that after you prepared for your INI-CET exam, you'll be like this child. You'll be beaming with confidence. You'll be like, bring it up. I'm ready for any question. But please remember these 3 advices. The first one is that NEET PG and INI-CET are not different exams. NEET PG some consider as easy, INI-CET some consider as difficult, but that's not the case. There is no difficulty levels that change in NEET PG and INI-CET. The only difference is the type of questions. In NEET PG, you might be asked a single level or single layered question where they may ask you, they'll give you a question and they'll ask you what is the diagnosis. But in INI-CET, they'll frame it with two layers. They'll ask you what is the diagnosis, and also they'll want the treatment of that. So you'll have to decode these two layers if you want to answer INI-CET questions. They're not difficult questions, they're just more layered. The second thing is that INI-CET examiners love to give long clinical questions, and you'll be lost in this sea of words. But what you have to do is you have to save time and focus on the keywords, which we'll be doing in this session as well. We'll see these long questions and we'll try to focus on the keywords that will help you clinch the diagnosis and get you the answer. And the last one is, because it is an INI-CET exam, they're not going to give you the answer that easily. There will always be these two similar options like tomato and tomato. There'll be two similar options. You'll have to not get confused by the other incorrect option. You should always mark the right option. So read the question carefully, read the options carefully. Don't get tricked by that one single proxy option and answer the right one. Okay, so with all of these advices in mind, let's go into our questions. So here is a fairly simple question, a kind of a recall question asked last year. I framed it a little differently. So which of the following muscles help in overhead abduction of the arm? Your options your options are serratus anterior and trapezius, deltoid and supraspinatus and infraspinatus, and serratus anterior and supraspinatus. So what they're asking is, from this 90 degree of abduction to about 180 degree of abduction, which are the two muscles that are helping you? I'll wait for 10 seconds and then we'll move on to the explanation. Fairly simple. I'm hoping few of you answer. Anyone who knows which are the muscles that help in abduction, overhead abduction specifically? Okay, let's go to the answers now. So overhead abduction, so this is the thing that you have to remember. This is the concept that you have to remember, that initiation of abduction is carried out by the supraspinatus muscle. It is 0 to 15 degrees. And then deltoid helps in abduction from 15 to 90 degrees. But after that, from 90 all the way till 180 degree, the muscles that help in these overhead abduction are serratus anterior and trapezius. These are the two muscles that help in overhead abduction. So the answer is serratus anterior and trapezius. I hope this is clear. A very straightforward question to start off with. Let's go to the next question, and this was an INI-CET December 2020 question. Hello, Dr. Akshay. So for non-union, a drug that can improve chances of union. So the options are calcium phosphate, calcium sulfate, PMMA, and bone morphogenetic protein. So these are your four options. This question is mainly asking you about the bone graft substitute that helps in improving chance of union in a case of non-union. Okay, so this is something that is not usually covered in theory sessions. No one talks in detail about bone graft substitutes, and that is why I thought I'll include this in my session today, because this is an untouched concept. So let me first ask you a simple question. Okay, Shabir is saying it is PMMA. Okay, I'll wait for a few more answers. Okay, let's approach this question a little differently. Okay, you've all gone to clinics, you've all done your internship, or you've done it, you've gone to ortho posting. So you've seen many cases of bone grafting being done. Which is the most common site of bone graft that is used? More commonly in the operations when they do, which is the most common site that they'd use for bone grafting? Okay, so that is an iliac crest bone graft. So normally what we see in clinics is we use an iliac crest bone graft, but here we are talking about bone graft substitutes. So remember that even if it is a bone graft or a bone graft substitute, they all need to have some common properties if they want to promote bone healing. And mainly there are these three properties that are important, that is osteogenesis, osteoconductivity and osteoinductive property. Okay, so what are these properties? So osteogenesis, meaning that this graft or the substitute that you use should have osteoblasts in them so that it can directly promote bone healing. So osteogenesis is when there is osteoblasts which will directly promote bone healing. Okay, so we don't have a lot of components like that. The only example is mesenchymal stem cells, which can convert to osteoblasts and they can promote bone healing. Then comes osteoconductive property. This osteoconductive property is not direct bone healing property. It is a kind of property where it forms meshwork. So what this component will do is it will form a meshwork along which bone can form. Okay, so this has a scaffold property, or it will form a meshwork. Okay, example for these are calcium phosphate, calcium sulfate and polymethyl methacrylate, which is also called as bone cement. Okay, in bone cement the major component is polymethyl methacrylate. So these are all osteoconductive components. Shabir, the one that you answered was an osteoconductive property. Okay, but what we are looking for is actually osteoinductive property, where one component produces growth factors. It produces growth factors, and this growth factors will promote the host bone. It will promote the host bone to increase its bone healing. Okay, it is not directly causing bone healing, it is promoting the bone to cause bone healing. So here the question they're asking is that there is non-union of a certain fracture. Let's assume it is humerus shaft fracture, and they want a component that can increase bone healing in that host bone. So we are looking for essentially an osteoinductive property, and the example of that is bone morphogenetic protein, BMP. So the answer here is bone morphogenic protein. All the others are osteoconductive. Okay, all of the others are osteoconductive. BMP is the only one that is osteoinductive. Next, let's look at the third question here. A 35-year-old male presents to the emergency department after falling from a ladder while painting his house. He landed awkwardly on his left forearm and complains of severe pain and swelling. On examination, the forearm is tense and swollen with marked tenderness on palpation. Passive stretch of the fingers elicits excruciating pain, and patient reports numbness over the dorsal aspect of the hand. Distal pulses are present but weak. Which of the following condition is the patient most likely experiencing? And your options are radial head fracture, Volkmann's ischemic contracture, Monteja fracture dislocation, and compartment syndrome. Anyone who can give me this answer? See, let's talk about the approach. So I told you that INI-CET examiners love to ask long questions. They like to make you get lost in this this sea of words. But the thing is, you have to focus on keywords. So first, let's try to find out what are the keywords here that can help us clinch the diagnosis. So look at this long question and let's try to find out the keywords that will help us clinch the diagnosis. So here I've marked the keywords. These keywords here: forearm is tense and swollen, marked tenderness on palpation, passive stretch of the fingers eliciting excruciating pain, numbness over the dorsal aspect of the hand, and distal pulses are present but weak. Okay, so looking at only these words, we can tell that the answer is correct, Shabir. You are right. It is compartment syndrome. Good evening, Sonu. It is compartment syndrome. So the answer here is compartment syndrome. But I wanted to focus on a few things. So whenever I ask my students what is the features of compartment syndrome, they'll just raise their hand like this and they'll tell me that there are 5 P's. They'll tell there is pain, there is paralysis, there is paresthesia, paral, and pulselessness. So these are the 5 P's. But do you see all these 5 P's in every case of compartment syndrome? Because focus on the question here. One of the statement here says that distal pulses are present. So pulses are present. Although paresthesia is there, although there is passive stretching of the fingers, pulse is still present. So is pulse also an indicator that will help us rule out compartment syndrome? Is the question that I want you to inquire. I want you to understand. See, if you want to know that, right, let's just agree that this is compartment syndrome, but let's go into the concept of compartment syndrome. Let's understand what is compartment syndrome. If you want to understand about these 5 P's and how they act, you have to understand that, see, compartment is an osseofacial compartment where you have muscles, where you have a nerve, and where you have vessels. So this is an osseofacial compartment. Okay, when the compartment pressure rises to such a level that it decreases the tissue perfusion. It can be because of fractures, burns, or any other reason. But if the pressure in the compartment increases to such a level that the tissue perfusion comes down, then you call this as compartment syndrome. And what happens in compartment syndrome? Let's understand this step by step. So when the compartment pressure increases, in early stages, what you see is an increased venous pressure, because of which there will be decreased perfusion pressure, and that will result in decreased tissue perfusion. So this is what happens first. Venous components are getting involved first, and because of which you'll start having features of muscle ischemia and nerve ischemia. This is when you get stretch pain. So this is why it is the first sign to appear in compartment syndrome, which you can appreciate early, and you can treat an impending compartment syndrome. Okay, but if this keeps happening, what will happen is this decreased perfusion pressure and muscle ischemia will result in increased capillary permeability, which will result in increased exudate, which again will cause increased compartment pressure, and this is a whole vicious cycle which will keep repeating. In late stages, much later, you will get decreased arteriolar pressure, and that will result in arteriolar closure, and this is when maybe you will get symptoms of pulselessness. So understand this one thing, that pulselessness is a poor indicator of compartment syndrome. It is a poor indicator of compartment syndrome. So even if distal pulses are present in that question, the answer still becomes compartment syndrome, because pulselessness is not one of the reliable indicators. Okay, so then let's understand about what happens as compartment syndrome progresses. We know that muscle ischemia will set in, nerve ischemia will set in 4 hours. There will be reversible damage to the muscle, and then there will be some more ischemia, and by 8 hours this muscle will have completely necrosed, and also nerve also by 8 hours will undergo neuropraxia and will have an irreversible damage. So at this point, the last sign that you will see of compartment syndrome, this again is an INI-CET question, which is the last sign that is seen in compartment syndrome, because this muscle ischemia will undergo irreversible changes. The last sign that you will see is paralysis. Paralysis will be the last sign that you will see, and eventually it will form a VIC, that is Volkmann's ischemic contracture. That is a sequelae of a neglected compartment syndrome in the long run, when there is necrosis and the length of the muscle reduces. Okay, so this is what happens in compartment syndrome. These are the 5 P's that students love to talk about, but understand the sequence of the 5 P's. Starts with pain, which is the most important one, goes till pallor, pulselessness, but the last sign is paralysis. Don't get confused by this chart here. The last sign is still paralysis. Okay, now, pain in the key as a keyword in one of the questions can be of different types. They can give you pain on passive muscle stretching, the way it was given in this question, or they can give you pain out of proportion to injury, or pain not relieved by analgesia, or pain not relieved by immobilization. All of these can be keywords, and by searching them, you can clinch the diagnosis of compartment syndrome. Okay, is this clear? Now let's discuss another question. What are the sites where compartment syndrome is seen? Which is the most common cause of compartment syndrome in adults? We'll start with adults. Can someone tell me which is the most common cause? Hello Ranjana, good evening. Yes, can someone tell me which is the most common cause or fracture causing compartment syndrome in adults? No one knows the answer? Okay, see, the most common one is a tibial diaphyseal fracture. Okay, it is in the leg, anterior compartment, and to be specific, if they ask you which fracture, it is tibial diaphyseal fracture. This tibial diaphyseal fracture, which is more common. But if they ask you the same question in children, the answer changes. Okay, in children, it is supracondylar humerus fracture causing compartment syndrome of the forearm. Okay, so these are two variations of a question. In adults, most common is tibial diaphyseal fracture, anterior compartment of the leg, and in children, it is supracondylar humerus fracture. Other sites can be hand or the foot. Okay, so this is an important thing. And the answer again, what is the treatment? So if they ask you what is the treatment, again in INI-CET they might confuse you. They might tell you that there is a tibial diaphyseal fracture that has undergone compartment syndrome, and they'll give you two options for the treatment. One, they'll tell you fasciotomy of just the anterior compartment. Another option, they'll tell you fasciotomy of all the compartments in the leg. And which will you choose? Which should you choose? See, the ideal answer for treatment of compartment syndrome is emergency fasciotomy of all compartments of the leg, not just the anterior compartment. It is all compartments of leg, and preferably within 8 hours. Why within 8 hours? Because then these irreversible changes to muscle ischemia and nerve ischemia will be prevented. That is why emergency fasciotomy of all compartments, preferably within 8 hours of onset of symptoms, is the ideal treatment for any case of compartment syndrome. Is this clear? Don't get confused. If they give you one compartment and all compartment, choose all compartments, because that is the best answer. Okay, now to ease out a little bit, I've put a little bit of these nuggets of advices in between these questions so that I don't bore you with my lecture. So let me begin with my first advice. Recently I've been talking to a lot of students about their INI-CET exams and NEET PG exams, and they've all been telling me, whenever I ask them about INI-CET exams, they always tell me that this is not their serious attempt. They may be an intern, or they may be people who are just studying for NEET PG. They tell me, some tell me that this is not their serious attempt, and some of them tell me that they are not focusing on INI-CET. They're just focusing on NEET PG, and INI-CET is like a mock exam for it. And for all of them, I'll give you a single advice, and you might hate me for giving this advice, but I'll tell you, don't be like Dhoni. Because Dhoni, every year everyone tells him that this is your last season, but he goes on to play more and more competitive cricket. But you shouldn't be like him. You shouldn't go for competitive exams again and again. Whenever you go to give a single competitive exam, always keep in mind that this should be my last exam. At least have that mindset that this will be my last exam, irrespective of whether it's your internship batch, whether you've not prepared for INI-CET or any of those conditions. The mindset should be that this is my last exam. Only when you have that mindset will you be able to get optimum results for every exam that you give. And I'm not saying that you'll end up clinching a seat in the INI-CET exam, but at least you'll end up getting the best of your abilities if you take this as your last attempt or the last competitive exam that you will give. Okay, so that was my advice. Let's go back to questions again. So this is a 26-year-old male who sustained a road traffic accident. He's been brought to the emergency department. You receive the patient, he undergoes the ATLS protocol, and you diagnose him with a shaft of femur fracture. You admit the patient and you prepare him for surgery, and you require to get fitness from a lot of people. So for 30 hours he is not undergoing surgery. So you admit the patient, you prepare him for surgery, but 30 hours later this patient develops shortness of breath, and when you examine him there is petechiae over his axilla and chest. D-dimer test is done, it is negative. What is the diagnosis? Is it hemorrhagic shock, fat embolism syndrome, pulmonary thromboembolism, or infective endocarditis? Okay, I'm getting a few answers here. Kumar Saurav, Shweta, all of you. Okay, but let's not learn it this way. Okay, if you're approaching any question in INI-CET, like I've told you, I want you to improve your approach as well, because in this session we are not just talking about solving orthopedic questions. We're talking about the art of solving MCQs. So first tell me the keywords that are helping you diagnose them. Yes, Kumar, Dr. Shweta, Shabir, can you tell me a few keywords that have helped you clinch this diagnosis? Although all of you are right, very good on answering that, but I want you to tell me the keywords that you use to clinch this diagnosis of fat embolism. See, I don't mind any answers. Okay, see, if I ask you what is 2 plus 2 and you answer 22 also, I don't mind, but keep answering. Please keep telling things in the comment box, so that keeps me running, that keeps me going. All right, so I just want all of you to keep answering. Very good, Shabir. Fat, okay. Femur fracture, shortness of breath, petechiae. Okay. So all of you are right, but I think one thing that you're all missing out is the timing. Isn't this important? 30 hours later, isn't that important as well? Because these same conditions, the same shortness of breath can come even in acute cases. If patient is going into hemorrhagic shock, it can even come later on. If it is much later, it can be because of thromboembolism. These features can again come. Okay, so even the timing is important. Very good. I love all your answers. All your points are right. Fracture shaft of femur, shortness of breath, correct. Petechiae in his axial anches, that is also right. Another one you have to remember is the timing. Okay, 30 hours later is also a very important kind of keyword to remember. Okay, so fat embolism is the answer here. You're all right. So shaft of femur, you'll have petechiae, subconjunctival petechiae. You'll also have axillary petechiae and all of these because of emboli. So what is happening in fat embolism syndrome? Although you all know this, let's quickly go through it. So what happens is because of long bone fractures in adults, mainly in adults, because in the marrow there is a lot of fat involved. Whenever there is a fracture of the long bone, what will happen? So I have a bone here. I have an adult bone here. So when there is a break of this adult bone, there is a lot of fat in the marrow, and this fat will then disperse outside, and there will be these ruptured capillaries which will take up this fat, and slowly within 24-30 hours, what happens is this fat from the capillaries will then go into the circulation, and once it goes into circulation, it might form an emboli, and this emboli can then dislodge into your brain. It can go into the skin, it can go into the lung, it can go into the retina, and all of these will result in different complications as we know it. Okay, so that is fat embolism syndrome, and this whole phenomena takes 24 to 72 hours. So always be in the lookout for this timeline. These hours are also very important. Okay, in fat embolism syndrome, there are two other things you need to remember. One is the chest. In the X-ray chest, what will you see? What appearance is seen? See, you can see here what appearance is seen in chest X-ray, and also if you can tell me what is seen in the fundoscopy, what is seen here, what are these two ophthalmology and X-ray findings that you get? So you have something called as a snowstorm. Hello, mixed bag by Subho. So you have something called as the snowstorm appearance that you see, because you see a lot of these artifact kind of things. So snowstorm appearance, and you will see cotton wool spots. You will see cotton wool spots. So these are the two things that you will notice in fat embolism syndrome. Then coming to the criteria, the Gerd and Wilson's criteria. You have to remember this as well. And I know it is very difficult to remember Gerd and Wilson's criteria because it has so many components. And that is why I've made an easy way for you all to remember this. Just remember it as Gerd and Wilson have 5 parts. They fart to stay fit. So you can see here 2 gentlemen. This is Gerd and this is Wilson, and both of them, to stay fit, they fart. Okay, so what is the mnemonic here? I mean, what is the thing that we're trying to remember? We're trying to remember the major criterias of the Gerd and Wilson's criteria and the minor criterias. Okay, the major criteria you can remember them by PACS, and the minor criteria you can remember them as FART, FIT. Okay, and then how do you diagnose them? 1 major and 4 minor criteria is suggestive of fat embolism syndrome. So look at this. You can take a screenshot or anything of this. This will help you remember Gerd and Wilson's criteria. Okay, major criteria: lung is pulmonary edema, skin is axillary petechiae, brain is CNS depression, eye is subconjunctival petechiae. So in the question they can give you any of these features. And minor criteria: fever, anemia, retinal emboli, thrombocytopenia, fat globule in both sputum and urine, increased ESR, and tachycardia. Okay, all of this is Gerd and Wilson's criteria. And then this was the differential I was talking about. So if the timeline was just given 2 hours, then I would be more inclined to answer it as hemorrhagic shock. Because it is 2 days, I'm telling it as fat embolism. If it was 2 weeks, again I'd consider it to be some kind of thromboembolism, pulmonary thromboembolism. Okay, so the timeline is also very important when you're diagnosing cases of fat embolism syndrome. Then coming to treatment, I know all of you are aware of this: high flow oxygen, 12 liters per minute, IV fluids, then high dose corticosteroids to prevent pneumonitis, and mechanical ventilation with high PEEP value. Okay, is this clear? So let's move on to our next question. So this was fat embolism syndrome. Let's move on to our next question. It's a trauma based question. It is a recall question asked previously in an INI-CET exam. An 83-year-old lady comes with history of trivial fall in the bathroom. Following the fall, she complains of pain and swelling along the wrist joint. X-ray was done, shown here, and your orthopedic resident instructs you to perform close reduction and apply cast to this patient. Which of the following is the right method of close reduction to be followed? Is it traction countertraction followed by palmar flexion of wrist followed by ulnar deviation and supination? Or is it palmar flexion of wrist, ulnar deviation and pronation? Is it traction countertraction, dorsal deviation, radial deviation and supination? Or is it traction countertraction, palmar flexion of wrist, ulnar deviation and pronation? Even the order is important. Okay, I'll give you a little time because there's a lot of words here. and the options also seem very similar, so you'll need little time to answer this question. Okay, secondary questions again. Look at the x-ray. I'll focus on the x-ray for some time. Okay, look at this x-ray as well, and if you can tell me what the diagnosis is. So this is a layered question. First you have to know what is the diagnosis, then only we can go into the treatment. So first thing, let's understand what the diagnosis is. Can you all tell me what the diagnosis is here? What type of fracture do you see in this x-ray? Yes, Shabir, you're right. This is a Colles fracture. How do you make that out? See, whenever you get a fracture, you get an x-ray of a distal radius, always see where the fracture line is. Okay, see in both the views where the fracture line is. If it is not in the articular rim, then you can call this extra articular fracture. Then you look at the lateral view. In the lateral view, you see whether it is dorsal or volar. How do you make that out? Look at the position of the thumb. So wherever the position of the thumb in x-ray is seen, that side is volar. The opposite side is dorsal. Okay, so can you see here the tilt is more dorsal. So can you tell me which is this dorsal fracture of the distal radius, which is extra articular? That has to be Colles fracture. Okay, so we have diagnosed this. We got the first layer correct. The diagnosis is Colles fracture. Now let's see how to reduce Colles fracture. Anyone who wants to take a dab at this? Anyone wants to tell me the answer before I move forward? Shabir, you're right. You answered it as Colles fracture. Can we go a step further and you can tell me what is the correct method of reduction? Okay, Shabir says it's D. Anyone else with a different answer or a similar answer? See, you can answer anything. A wild guess is also all right with me. But please attempt these questions, because if you do attempt them, you will understand it much better. Okay, so we've established that this is a Colles fracture. Now we have to understand what are the displacements seen in Colles fracture. So there is a popular mnemonic to remember displacements of Colles fracture. Why are we discussing displacements? Because if you want to treat any fracture, we have to reverse the displacements. That's logical, right? You have to first know the displacements and then you have to treat it. Only then will you be able to do the manipulation. Okay, so the displacements is, mnemonic is DILS. There is dorsal displacement and dorsal tilting. There is impaction. There is lateral tilting and lateral shift, and there is supination. So these are all the displacements that are seen in Colles fracture. So an easy way of remembering this, I usually put this slide forward. So Kohli stands for Virat Kohli, and he's the heartthrob of the nation. So DILS for Kohli. Okay, so dorsal tilt, dorsal displacement, impaction. If they ask you which is the most important displacement, it is impaction. Okay, because it leads to radial height shortening. And lateral tilt, lateral displacement, and supination. Now, how do we reduce this fracture? We have to remember these displacements. So what are the displacements? Let me write them down. D, I, L, S. And I know which is the most important displacement. It is impaction. Impaction meaning the two fragments have gone within one another. Okay, resulting in radial height shortening. Now, how do we disengage this impaction? How do we disengage this impaction? We have to give traction, counter traction. So for this impaction, the first thing that we do is traction, counter traction. Okay, look at this animation here. Can you see how after giving traction, counter traction, the two fragments have moved away from each other? Okay, that is the first step. Second thing, we are looking for replacing this dorsal displacement. Dorsal displacement meaning it is somewhat like this. Now, to reverse dorsal displacement, we have to do palmar flexion. So the next step is to do palmar flexion. Look at this animation again. If we do palmar flexion, that angulation gets corrected. It gets corrected. Okay. So that is the two things that we've done. The next thing we are looking for is lateral shift. So we have to convert the lateral shift. So lateral shift meaning the hand is somewhat like this. Okay. So we want to get it inwards. We want to get it medially. So we call this as ulnar deviation. This is radial deviation. This is ulnar deviation. So we have to do an ulnar deviation. So the third step is to do an ulnar deviation. Now look at this animation here. First I'll do traction, counter traction. I'll disengage it. Now I will do an ulnar deviation, and can you see how it is corrected? This is the correction. Now the last correction remaining is supination has to be converted. Supination is converted by doing the opposite, that is pronation. So what is the ideal movement that you have to do? Disimpaction by traction, counter traction. palmar flexion of the wrist, ulnar deviation, and pronation. So these are all the movements that you do to reduce a Colles fracture. And after doing that, what kind of cast will you put? Can someone tell me what kind of cast is used in Colles fracture? So see, the cast that you put goes into palmar flexion and ulnar deviation. So your hand will be somewhat like this. It will be similar to how these handshaking cast, correct Shabir? So why is it called a handshaking cast? Because if you see in kings or in aristocrats, whenever they greet someone in this fashion. Can you see how the hand is placed? It is somewhat in palmar flexion and little bit in ulnar deviation. So this is a handshaking cast. Okay. So this is all that you need to know about Colles fracture. The answer, as Shabir has told, is D. First is traction counter traction, then is palmar flexion, then ulnar deviation, and then pronation. You don't have to by heart this. If you can remember the displacements and if you reverse them in your head, if those animations can play in your head, then you'll be able to figure out this answer. Okay. Now let's go into another advice, a small advice before I go into my next question. So a lot of people ask how many questions is enough to attempt in INI-CET exam? How many do you have to get correctly? See, gone are the days when 140 answers were correct answers were enough for you to get a good rank in INI-CET. If you want to get a rank from 1 to 200, at least you have to attempt 165 to 180, hoping that these become correct. Okay, you have to at least get 165 correct answers if you want to get a good rank between 1 to 200 and so forth, because the competition has increased and also the level is higher now. Okay, so that is how many questions you have to go for. So again here, a recall question from July 2021. So they'll give you these fracture names and they'll give you its description and they'll ask you to match them. This is a direct question that I've picked up from the paper. Match the eponymous fracture. So the names are Rolando fracture, Bennett fracture, Boxer's fracture, Barton's fracture. Options, descriptions are fifth metacarpal neck fracture, intra-articular T or Y-shaped fracture, base of first metacarpal with 3 or more fragments, intra-articular distal end radius fracture, and intra-articular fracture dislocation of base of first metacarpal, 2 fragments. And you have these 4 options in front of you. I know it's going to take some time for you to match the ones and the ones and numbers. So I'll give you a little bit of time. I'll give you maybe 15 seconds. It's a simple question. It's going to take some time, but it is a very simple question. Only thing you have to remember are all the eponymous fractures. Anyone would want like to take a dab at this? Anyone would like to answer this? Okay, Mariam says it's B. Shabir says it's B. Any other answers? Okay, let's go on solving this question. So first let's understand what is a boxer's fracture. So look at this animation here. Can you see how because of punching on a wall, there is a fifth metacarpal neck fracture. Fifth metacarpal neck fracture, and this is because of boxing injury, and that is why we call it as boxer's fracture. So simply remember this animation, you'll be able to decode it, that it is a fifth metacarpal neck fracture, extra articular fracture. The treatment for this, as you can see here, is ulnar gutter splint put in the position of hand function. So this is the position of hand function. So whenever you're putting any kind of cast for metacarpal fractures, you will put them in a position of hand function so that the intrinsic function is not lost. Okay, so this is the boxer's fracture. Let's look at the second one. Look at this animation here. Look at it carefully. You can see the abductor pollicis longus. You can see the adductor pollicis as well. Can you see how when there is a fracture at the base of the fifth metacarpal, when there is a fracture at the base of the first metacarpal, you can see one of the fragments, it's getting pulled by the ligament. This is resulting in not just a fracture, it is resulting in a fracture dislocation. So there is a base of first metacarpal fracture dislocation, and this is usually 2 fragments, involving 2 fragments. What is this? This is Bennett's fracture dislocation. Okay, it's not just fracture. I know a lot of papers mention it just as fracture, but it is a fracture dislocation. That is the main difference between a Bennett's fracture and a Rolando's fracture. Bennett's fracture is a dislocation where one of the fragment is getting pulled away and there are essentially two fragments. Then look at the next animation here. Here you will see that the fracture is again occurring in the same site. It is at the first metacarpal base. But here there are more than two fragments and there is no dislocation. All of the fractures are there. There is comminution, but there is no dislocation of the fragment. So this is again base of first metacarpal fracture but no dislocation, and usually three or more fragments are present, and usually the fracture is in Y or in T format. Y or in T format. So this is the main difference between a Bennett's fracture and a Rolando's fracture. Bennett's fracture is a fracture dislocation involving two fragments. Rolando's fracture is just a fracture of the base of the metacarpal with three or more fragments. It can be T or Y shaped. The last one that we saw was a Barton's fracture. So simple way to remember Barton is ART stands for articular. So it is an intra-articular fracture of the distal radius with carpal subluxation, and it can be two types. If it goes volarly, volar or dorsal. So you can have volar Barton or dorsal Barton. Okay, both of these are possible. Now, since we've discussed one type of distal end radius fracture, let's discuss all of them. We all know about Colles. So how do you differentiate fractures, distal radius fractures? You divide them into extra-articular and intra-articular. Extra-articular, if there is dorsal angulation, like you see here, it is Colles fracture. If there is volar angulation, it is Smith's fracture. If there is an intra-articular fracture, then it is Barton, and Barton also can be of two types. It can be dorsal, it can be volar. Then there are two others you have to remember in intra-articular fracture. One was Barton. Two others you have to remember. One is an isolated ulnar styloid fracture. Isolated ulnar styloid fracture. This is called as, it's called as Schoffer's fracture. Okay, it is called as Schoffer's fracture. And one more that is not mentioned a lot in most of your lecture videos is there is another intra-articular fracture where there is depression of the lunate fossa. So can you see here, the lunate bone goes and smacks into it, resulting in depression of lunate fossa. This again is an intra-articular fracture. It is called a die punch fracture. Please remember this one extra point. It is called as a die punch fracture. Okay, so three intra-articular, two extra-articular fractures of distal end radius that you have to remember. Now the answer is C here. Okay, can you see Rolando fracture is, oh, I'm sorry, the marking is wrong here. That is B. Okay, I'm sorry, it is B. So Mariam and Shabir, you both were right. It is B. Now, since that question has already been covered, I thought I'll make another eponym fracture type of question, but with lower limb fracture. So please look at this question. Here, the fractures mentioned are Jones fracture, aviator fracture, jumper's fracture, and March fracture. And the options given are stress fracture of shaft of metatarsals, second metatarsal more than third, H or U-shaped vertical fracture of the sacrum, fracture of the base of fifth metacarpal at the junction of metaphysis and diaphysis, and talar neck fracture. Can someone guess this? You have four options, four fracture eponyms. One is Jones fracture, one is aviator fracture, one is jumper's fracture, and one more is March fracture. Okay, Shabir says it's A. Anyone else has a different answer? Or anyone with a similar answer? Anyone agrees with Shabir? Okay, we'll go into what these each fractures are. Let's discuss a little bit about them. First, we'll discuss about aviator's fracture. Like you all know, aviator means the pilot. Usually these fighter jet pilots, all of them, these are aviators. Hello, Dr. Meenakshi. Welcome to the session. So aviator fractures essentially are seen in pilots who are called as aviators. What happens back then was these fighter jet pilots, whenever their flight was compromised, they used to eject out, and through the parachute they used to land down, as you can see in this animation here. And whenever they landed in a very aggressive manner. They landed with forced dorsiflexion, and their foot would go somewhat like this. And this resulted in a fracture of the talar neck. There was a talar neck fracture, which was seen more commonly with these aviators, and that is why talar neck fracture was called as aviator's fracture. It was called as aviator's fracture. Okay, so that is the way these names are given. Talar neck fracture, also called as aviator's fracture. It is the most common fracture in talus, and one thing you have to remember is the complication. High chances of talar body AVN is seen in talar neck fractures. And two more things that you need to remember. I think this can be appreciated by people who watch this popular Netflix series. Okay, so you know that in this series it is based in a city called as Hawkins. So I've associated talus to the word Hawkins. So whenever you see the word Hawkins in any of the question, remember that they're talking about talus fracture, because Hawkins sign is seen in a talus fracture that is healing without AVN. It is a good sign, it is a positive sign. And Hawkins classification is denoted for talar neck fractures. Okay, so whenever you see this word Hawkins, remember talus. Okay. Next, let's talk about jumper's fracture, and I have a very interesting story to tell you. This is a story that most men can relate with, Indian men can relate with, that we usually fall in love with a girl, we fall head over heels for her, and we want to see her every day. So what we do is we try to go to her house, jump through the balcony and go and see her secretly. And when the father of the girl comes, what we do is we'll jump from the balcony, usually from the first or second floor. We'll jump and we land on the heel. When you land on both your heel, there is a high chance that you will get an intra-articular bilateral calcaneum fracture. Okay, bilateral intra-articular calcaneum fracture, which is called as a lover's fracture or a Casanova's fracture. Okay, is this clear? Now, same story 2 years later, when the girl will reject you or will dump you, what you will do is you will get so sad that you will go on top of a building and you will get so depressed that sometimes you might commit suicide. So as you commit suicide, as you fall from the top of the building, you will land on the sacrum. And as you land on the sacrum, there will be a vertical H or U-shaped fracture in the sacrum that is called as suicidal jumper's fracture. So this is how you can remember lover's fracture and suicidal jumper's fracture. Okay. So what is lover's fracture? It is bilateral intra-articular calcaneum fracture, also called as Casanova's fracture or Don Juan's fracture. Jumper's fracture is a jumper's fracture is also transverse fracture of the sacrum. Mechanism injuries again fall from height. Then the last one in the option was a march fracture. So march fracture is usually seen in freshly recruited military people who are put to rigorous marching training. So they do this marching training drill all throughout the day, and what happens is, because of the striking of the foot repeatedly, they will have a stress fracture mainly at the second metatarsal or at the third metatarsal, and this will usually have excessive periosteal reaction, and this is called as march fracture. Okay, this is march fracture because it involves a lot of marching. It is also seen in dancers as well who follow a strict routine. So stress fracture of shaft of metatarsal, if they ask you which more commonly, it is second metatarsal, more common than third metatarsal. X-ray I've shown you, there will be periosteal reaction, and treatment is putting a non-weight bearing short leg cast. So this last one, Jones fracture we all know is the fracture of the base of the fifth metacarpal, sorry, it is metatarsal, okay, not metacarpal. Sorry, that is an error here. Metatarsal at the junction of metaphysis and diaphysis. Okay, so this is the answer. So you were right, Shabir was right. It is A. So another little nugget of wisdom here is, whenever you're sad, you will be in this whole phase of studying, and if you don't have any other source of happiness, just remember the C6 vertebrae, because we as orthopedic surgeons or spine surgeons usually use this reference. Always remember the C6 vertebrae, and how C6 vertebrae is always happy carrying your head around every day. You also can find some happiness even in this difficult phase. Okay, so a little bit of breaks so that you don't get bored of me. Now, in because we've talked about C6 vertebrae, let's talk about a spine MCQ, because spine MCQs have been asked in INI-CET. Scoliosis questions have been asked before, so I'm predicting that there can be a question from scoliosis coming. So look at this question here. A 14-year-old lady with adult idiopathic scoliosis presents to the OPD with a Cobb's angle of 30 degrees and rises grade of 5. What would be your preferred treatment option? The options are deformity correction surgery, growth rod correction, Boston brace, and Taylor Knight brace. You have four options here, and I know few of the words here you might not have heard, but please apply whatever knowledge you know on scoliosis. That is enough for you to answer this question. Whatever basic knowledge of scoliosis you have is enough to answer this question. See, the keywords here are mainly 14-year-old child, adult idiopathic scoliosis, Cobb's angle of 30 degree, and Reiser's grade 5. Okay, and these two here are surgical options, these two are braces. Two surgical options, two braces. So if you can't pinpoint the option, at least tell me, would you do surgery in this case, or would you manage it conservatively? Is it a big curve or is it a small curve? Okay, I think you need a little bit of initiation as to what scoliosis is. So let me give you a little bit of knowledge about what scoliosis is, and then we'll move forward. So scoliosis, as we all know, is deviation from the normal vertical line of the spine. It is a three-dimensional deformity of the spine, and the most common type, there can be many types of scoliosis. There can be congenital, there can be neuromuscular scoliosis, but the most common type is adult idiopathic scoliosis. It is adult idiopathic scoliosis. Okay. Now, whenever you're treating scoliosis, you have to keep two things in mind. One is, what is the severity of the scoliosis presently? When a child comes to you, how severe is the scoliosis presently? And second thing is, because the child will keep growing, what is the progression of the disease? For how long will this curve progress? You need to know these two things before you treat any scoliosis. So for knowing the severity of the curve presently, you take the Cobb's angle. What is a Cobb's angle? So you take the curve, end vertebrae of the curve. So you take one line from the upper end plate, one line from the lower end plate, and you take an angle of that. That is a Cobb's angle. So Cobb's angle normally is less than 10 degree. That means it is not scoliotic. Mild is 10 to 30, and more than 30 degree is severe. Okay, but 30 to 40 still is okay. Till 40 degrees is almost okay. All right. Then you have to know about progression of the curve. How can the curve progress? And for that, we have the Reiser's angle to know how much maturity, skeletal maturity, is still left in the child. Okay, Bharat Iyer says that surgery seems to be the way. Okay, let me just explain this concept, and then let's see whether Bharat changes his answer or remains the same. So Cobb's angle mainly is talking about severity at that point. Okay, it is talking about mild, moderate, severe based on scoliotic curve. But again, important is Reiser's grade as well. Reiser's grade will tell you how much progression of skeletal curve has happened. Okay, so grade 1, when you look at the iliac apophysis, so this whole thing is the iliac apophysis. So in the iliac apophysis, if there is fusion of only this much part of the quadrant, it is grade 1. If there is this much fusion, it is grade 2. If it has come till here, it is grade 3. If this much fusion of iliac apophysis is there, it is grade 4. If there is complete fusion, it is grade 5. So what does this grades mean? If a patient is grade 5, that means that there is no more skeletal maturity that is possible. But if the patient is grade 1, then you know that so much skeletal maturity is still left in that child. Okay, so now you have to understand Greiser's grade and Cobb's angle, and based on this, thank you Purni Shetty. So based on this, we have to then decide whether to treat it conservatively or surgically, and the cutoff here is 40 degree of Cobb's. If there is 40 degree of Cobb's and there is no much growth potential, then you can do conservative treatment. But if there is surgical correction, if there is 40 degree beyond curve, or there is a lot of growth potential left, then you might have to go for surgery. Now Bharat, I'll ask you the same question again based on this criteria. Now that you know, let's go back to the question. Now that you know that this is a 30 degree curve and patient is Reiser grade 5, would you change your answer, or you still think that surgery seems to be the answer? Anyone, it's not just for Bharat, for everyone. Do you think now that surgery is the answer, See, because riser grade is at the highest, it is grade 5. So there is no more potential for growth in this child. Child is already skeletally mature. And the Cobb's angle is just 30 degrees. Braces, right. Shabir, braces is the answer. So we've cancelled these two options. Growth rod correction is again a surgery. You don't have to go into detail about that. Okay, yeah, Bharat also changes his answer. So we have two options now. Two braces again. Boston brace or Taylor Knight brace. Which brace would you answer? Yes, Soumya, you're right. It is Boston brace. Okay. So two braces for INI-CET exam and for your NEET PG exam that you need to know about scoliosis. One is the Boston brace and another is the Milwaukee brace. And usually they'll give you an image-based question where they'll ask you to identify a Boston brace. So it might be difficult sometimes to differentiate between Boston and Milwaukee brace. So I made it a little easier. So Boston brace, at least for me, forgive me if it doesn't visual is not for you, it looks like a Boston bridal gown. It looks like this gown, and that is why if you see a structure of a brace similar to a gown, you can mark it as a Boston brace. And a Milwaukee brace has a lot of metal components in them. So if you see a lot of metal components, then you can mark it as Milwaukee brace. And the difference between these two is Boston brace and modified Boston brace is the most commonly used type of braces in scoliosis, but Milwaukee brace is actually more effective. It is most effective kind of brace. Okay, Milwaukee is more effective, but more commonly because of ease of usage we use Boston brace or a modified Boston brace that is being used. Okay, this is the surgery that is done. This is the correction surgery. If the curve was very big or there was a lot of potential for growth, then we would do this. We would do a deformity correction surgery with screws. Okay, Taylor's brace is not even used in scoliosis. Where is Taylor's brace used? Can you tell me where Taylor's brace is used? It is used mainly in dorsolumbar osteoporotic fractures. Dorsolumbar osteoporotic fractures. They have these metal rods within that prevent from flexion, prevent mobility of the spine. So dorsolumbar osteoporotic fractures, you can use a Taylor's or Taylor Knight's brace. Okay. So answer is Boston brace. Now let's move on to the next question. An 18-year-old boy suffered an anterior shoulder dislocation while playing basketball. Following the injury, he developed weakness of flexion at the elbow and lack of sensation over the lateral aspect of forearm. The nerve that could be injured is axillary nerve, ulnar nerve, radial nerve, musculocutaneous nerve. This question I want you to answer. Okay, Shabir says it's D, musculocutaneous. Any other answers? Any different answers? Okay, so the trick here, not just actually a trick, but the thing where you get confused is because in anterior shoulder dislocation, more commonly the nerve that is injured is axillary nerve. The most common injury is in the axillary nerve. So you might go on and tick axillary nerve as the answer. But if you read the full question, you will see that the features that they've mentioned of weakness of flexion at the elbow and lack of sensation in the lateral aspect of the forearm, both of these attribute to musculocutaneous nerve. So remember two important MCQs here. The most common nerve injured in anterior shoulder dislocation is axillary nerve, but there can also be chances of musculocutaneous nerve injury that can occur. And if musculocutaneous nerve injury occurs, you will have difficulty in elbow flexion because it gives a branch to biceps, and more ideally you will have paresthesia in the lateral aspect of the forearm. Okay, so the answer here is musculocutaneous nerve. Okay, so don't get confused between axillary nerve and musculocutaneous nerve. Now let's move on to the next question. A 23-year-old male epileptic patient presents with pain in the right shoulder region. Examination reveals right upper limb was adducted, internally rotated, and patient was unable to do external rotation of the shoulder. X-ray is given below. What type of lesion are commonly seen in this injury? This again is maybe a three-layered question. The first layer involves you diagnosing the answer, also getting to know the X-ray. The last one is to find out what pathological lesion happens in this type of injury. Okay, so first let's try to solve each layers. The first layer I want you to solve is what type of injury is this? what type of injury is shown in the X-ray is mentioned in the clinical features. What is this injury? Is it a fracture? Is it a dislocation? What type of dislocation is it? Okay, I'll focus on the X-ray also so that you get a better view. Can you see any sign that will help you understand what type of dislocation this is? Okay, few of them are telling this is posterior shoulder dislocation. Yes, bulb sign. Yes, correct. Yeah. So, what are the keywords that are helping you clinch this diagnosis? What are these important lines that are helping you understand the answer? It is the attitude, that is an adduction and internal rotation. And the most important line, whenever you're suspecting posterior dislocation, always search for unable to externally rotate the shoulder. If a patient is not able to externally rotate the shoulder, that means it is, yes, correct Shabir, that means it is a posterior dislocation. Now that you know that it is a posterior shoulder dislocation, yes, all of you are right. Soumya, correct, in adduction, internal rotation, attitude. But more importantly, it is external rotation of shoulder is not possible. That is one. Okay, so now what are the signs? See, I'm asking you here, what are the lesions seen in this injury? We know the injury is posterior shoulder dislocation. Now, quickly let's revise. What are the lesions seen in anterior shoulder dislocation? Do you know two signs that are seen in anterior shoulder dislocation? Two or three signs seen in anterior shoulder dislocation, some pathological lesions. Any lesions or anything that you know that you've studied about anterior shoulder dislocation, not posterior. You can tell me the anterior ones if they are more common. Yes, Shabir, it is Bankart and Hillsack. Correct, you're right. So, mechanism of injury, let's understand. See, the mechanism of injury in anterior dislocation is abduction, external rotation. In posterior, it is adduction, internal rotation. In inferior, it is severe hyperabduction. Now, whatever is the mechanism of injury will be the attitude. That means, in posterior dislocation, if adduction and internal rotation has caused the injury, the patient will come to you also in this locked position of adduction, internal rotation, and he will not be able to do the opposite movements. So take for example anterior dislocation. The hand will be in abduction, external rotation. He won't be able to do internal rotation, and that is what is Dugas test. Do you remember Dugas test, where you ask the patient to touch the opposite shoulder? He is not able to do it because he is not able to internal rotate and adduct in anterior dislocation. In posterior dislocation, adduction and internal rotation, he is not able to externally rotate. Okay, that is an important feature. And the light bulb sign that you just saw, both of that is there. In anterior dislocation, what happens is because of a damage. So I'll show you. So these are the two bones. Okay, let's focus on the bone here. So what happens is because of repeated dislocation, what happens to the labrum? So if there is repeated anterior shoulder dislocation, anterior aspect, anterior-inferior aspect of the labrum is getting damaged. And this damage to the anterior-inferior labrum is called as Bankart's lesion. And even if the bone gets damaged with the labrum, it is called as bony Bankart. So there is soft tissue labral Bankart and bony Bankart. And also here in the humerus, posterior inferiorly in the humerus also, you will have, because it stays like this after dislocation, it stays like this, there is an impaction fracture resulting here in the humeral head that will result in Hill-Sachs fracture. But imagine you have a posterior dislocation. Which labrum will be damaged? It is a posterior labrum that is getting damaged. So let's go back to that question. Let's go back to the question here. Look at all the options that you have. Look at the options that you have. Which do you think is the answer for posterior shoulder dislocation? This is not a case of anterior shoulder dislocation. So Bankart is not the answer. Bankart is not the answer. Bony Bankart is not the answer. Hill-Sachs is not the answer. The answer is posterior Bankart. C, correct, Shabir. It is C. Posterior Bankart is the one that is damaged. So they can give you a slight twist in the things that you already know. You know about Bankart and Hill-Sachs, they might ask you about posterior Bankart. So you just have to apply the knowledge that you already have to answer such questions. That's all, okay? So this is what is seen. So one thing in posterior shoulder dislocation, not able to external rotate. Second thing, you will notice reverse heel sack, and you will have posterior bank cut, opposite of an anterior dislocation. Okay. So the answer is posterior bank cut. Now let's talk about hip dislocations. Okay, 35-year-old man presents to the emergency with history of road traffic accident. He finds difficulty in bearing weight on the right lower limb, complains of right hip pain. Limb is in an attitude of flexion, adduction, internal rotation. What may be the likely cause? Is it fracture neck femur? Is it inferior hip dislocation? Is it posterior dislocation of hip? Or is it anterior dislocation of hip? I'll give you guys 10 seconds to answer this. Very simple question. You have to be able to answer this because in INI-CET they love asking about hip dislocations. Okay, again, what are the keywords here that have helped you identify the answer, Soumya, Shabir? In the question, what are these exact keywords that have helped you clinch the diagnosis? The attitude, very good. So here the keywords are flexion, adduction, and internal rotation. Okay, so we know that there are two types of dislocation, hip dislocation. One is pure hip dislocation, another is fracture dislocation. In pure dislocations, anterior and posterior, most common is posterior. In fracture dislocation, again anterior, posterior, and central dislocations. We know the attitude of a posterior dislocation, it is a dashboard injury. Look at this animation, it is showing you a dashboard injury, and after that focus on the attitude. So they'll show you the attitude now. So look at this animation here. Look at the attitude. The attitude is that of flexion, adduction, internal rotation. So that is what happens in cases of posterior dislocation. Most common is dashboard injury. Few other features, few other keywords which are not there in this question can be in other questions is shortening of leg, femoral head felt in the gluteal region, and also vascular sign of Narad positive. Hello Tarnath. So shortening of leg, femoral head felt in the gluteal region, and vascular sign of Narad positive. These are the keywords that you can expect to see in cases of posterior dislocation of hip. Okay. And this is how the X-ray will look. So what features will you be able to see in the X-ray? Let me mark all of them here. You will see shortening, you will see a broken Shenton's line, and also you can make out that there is some amount of rotation, internal rotation. How do you make out internal rotation? Very simple way, I'll show you in this. So can you see here, if there is internal rotation, can you see how this lesser trochanter is missing? Is not visible. But similarly, if it goes into external rotation, this lesser trochanter becomes more prominent. So here can you see that lesser trochanter is less prominent. That means that it is internally rotated. That means it is internally rotated. So just by one view, you are able to identify whether there is internal rotation or external rotation of the leg as well. Okay, and even adduction can be made out. So these are all clues that will help you diagnose posterior dislocation. Hip fracture dislocation and hip pure dislocation, what is the difference? Is that in fracture dislocation, it might not always obey this attitude of flexion, adduction, internal rotation, because it is an INI-CET exam. I'll have to prepare you for tricky questions as well. So sometimes they can give you a scenario of a fracture dislocation. So the only difference in fracture dislocation, anterior and posterior, is that this attitude will not be obeyed. That is, in posterior dislocation, you might not have flexion, adduction, internal rotation. You might have some other mixed attitude, but other keywords will remain the same. That is, you will see you will palpate the femoral head in the gluteal region, shortening will be present. All of this will remain the same, but conventional attitude will not be followed. Hello Arjun, welcome to the session. Now let's go into anterior hip dislocation. Here, I always like to give the example of this, which we commonly see on the streets, where the rickshaw driver keeps one leg on the opposite rickshaw. So what happens in anterior dislocations is the leg is going into hyperabduction, resulting in a dislocation, and that causes an anterior dislocation. And this is how the attitude in anterior dislocation is. Look at the animation here. There is flexion, there is abduction, it is away from the body, and there is external rotation. So it is Faber. Faber is the attitude. Okay, it is Faber. And other features you will see are true lengthening of the limb and femoral head felt in the groin, scarpas, or femoral triangle. Any of the three things can be given. Okay, and the X-ray will look somewhat like this. You should make out the broken Shenton's line, the lengthening, abduction. Also look at the lesser trochanter. You will be able to see more prominent lesser trochanter. That is a sign of external rotation. It is a sign of external rotation. Okay. It's the same thing in fracture dislocations also. Conventional attitude will not be followed. And last is central fracture dislocation. As an orthopedician, the biggest relieving factor is we don't have to do per rectal examination every time. The only time we have to do a per rectal examination is in cases of central fracture dislocation of hip, where you will be able to palpate the femoral head in the per rectal examination. Okay, because the femoral head gets impacted, breaking the medial wall, it goes inwards. Okay, somewhat like a protrusio acetabulum. So this is the algorithm that I want you to take a screenshot of. This will help you diagnose any case of hip dislocations. It can be fracture dislocation also, normal dislocation also. What you will do is, if you're suspecting a hip dislocation, first look for the keyword femoral head or globular mass felt in. If it is given in the gluteal region, then you look at the attitude. If the attitude is flexion adduction, internal rotation with limb shortening, it is a pure dislocation. It is a pure hip dislocation. If attitude is mixed, then it is a fracture dislocation. And if the femoral head is in the groin or femoral triangle, again look at the attitude. If the attitude is Faber, then it is pure dislocation. If it is mixed, then it is a fracture dislocation. But if on per rectal examination you're feeling the femoral head or globular mass, then the answer becomes central hip fracture dislocation. Is this clear? This one algorithm will help you treat every case. Any tricky question of fracture dislocation in INI-CET also you'll be able to answer with the help of this. Okay, is this concept clear? So the answer is posterior dislocation of hip. Now the next question that we are going into is somewhat of a celebrity. It's asked very frequently every year, either be it in the mid session or at the end session. They will always ask you one question from osteoporosis. So it is only warranted that I have to include a question from osteoporosis. So this is the question about osteoporosis. Which of the following is true statement about osteoporosis? Read the question carefully, read the options very carefully. Option 1 is the WHO definition defines osteoporosis as bone density 1.5 standard deviation below the mean T-score. Second option is most common osteoporotic fractures seen in the age group less than 70 years is vertebral fractures. Option C is bone scan has no role in diagnosis of osteoporosis. And option D is T-score compares BMD value obtained with a subject of the same age and sex. You have 4 options. Which of these is true? Can I get a few answers here? Which of these are true? No answer? Anyone wants to take a wild guess? See, because we study osteoporosis in detail, B or D. Okay, B or D. Okay. Any other answers? I accept these kind of answers as well. At least someone's trying. B or D is okay. Shabir, that was your attempt. Anyone else thinks 2 options might be right or they feel right? Or even you can tell me which option does not sound right at all. Even that is acceptable. Any other answers? Which option does not sound right at all? Which is definitely false? Okay, no one wants to try. Okay, we'll study about osteoporosis and come back. Let's shelve this question and come back to it after we've known a little bit about osteoporosis. So what is osteoporosis? So the definition of osteoporosis is that its bone density is 2.5 standard deviation below the mean of T-score. 2.5. Okay, so option A is wrong, is definitely wrong. Okay, then let's understand a little bit more of what this T and Z score is. And I know a lot of students are confused about what T and Z score is. Even Shabir is confused as to what T and Z score is. So let's understand this using a simple analogy. So as you were a child, when you had this marks card given to you, you would come back home with this marks card and you would give it to your parents, and your parents always had the same response. They'll always compare you with 2 people. One would be your sister, your elder sister, who's done much better than you in all the exams. She's like the gold standard. She's like the reference value. They'll compare you with them. Or they might compare you with the neighbor, Sharma ji ka beta. They might compare you with some in the neighbor who goes to your same class, who's your same age, who's written the same paper. So two types of comparison is there, and that is what is T and Z score. When they compare you with your sister, that is somewhat of a T score. If they compare you with a person, with a neighbor who goes to the same school, goes to the same exam, that is a Z score. See, what is the main difference? In T score, you're comparing your value to a reference value, a gold standard reference value. In Z score, you're just comparing it with a subject of the same age and sex. Now, which is better? Now, when I say which is better, I'm not mentioning this from your point of view, because for you, obviously, I'm referring with a neighbor would be better. But for your parents, the better score is to compare you with your ideal sister. And that is why T score is a better score. T score is a better score. So please don't get confused between these two concepts of what is T score and what is Z score. So your T score compares the highest value of BMD obtained for any site, maybe spine, hip or forearm, to a reference value, a gold standard reference value of a 30-year-old of the same sex and ethnicity. Whereas a Z score is comparing the BMD value obtained with a subject of the same age and sex, and there may be a lot of bias to it. Hello Lydia, welcome to the session. So do you understand this, Shabir? Do you understand what you made wrong? So D is not the option. See, D says that T score compares age and sex. This is wrong. This is actually not T score. This is a Z score that compares it. So statement D is wrong. Okay. So we are left with now statement B and statement C. So understand this, that in osteoporotic fractures, when there is a fracture, it is a fragility or a pathological fracture. So this pathological fracture, most common bone involved is vertebrae. Dorso-lumbar vertebrae is most common. Everyone knows this. But if you want to understand further, most common in more than 70 years is vertebrae. Most common in less than 70 years is distal radius. Please remember this fact as well, because I've told you in INI-CET they like to dig deeper. They won't settle with most common bone involved. They like to know more than that. So they might ask you most common fracture in less than 70 years, vertebrae. Most common in more than 70 years, distal radius fracture. Okay. Another fact you have to know is that hump, that kyphosis that comes in osteoporosis is called as Daviger's hump. Okay. So so this statement is also wrong, because it shouldn't be vertebral fracture. It has to be radial fracture. So the answer is bone scan has no role to play in diagnosis of osteoporosis. That is the answer, because bone scan is not the investigation of choice in osteoporosis. The investigation of choice is DEXA scan. It is DEXA scan. Okay, we do x-rays and other things. Bone scan will not give us any new information about osteoporosis, so it is completely useless in cases of osteoporosis. All right. So that was the answer. It is bone scan has no role to play in diagnosis of osteoporosis. Okay, so this is how in osteoporosis they can ask you more and more deeper questions. So I suggest that if you're preparing for INI-CET, study thoroughly about osteoporosis. Okay, although I'll cover most of it, study it in detail. Now, this is another concept that I wanted to explore. It is about different types of rickets. Diagnose the type of rickets based on lab results. And you know that there are different types of rickets. There is nutritional, vitamin D dependent type 1, vitamin D dependent type 2, vitamin D resistant rickets, renal osteodystrophy. So all of these are there. So can you tell me this lab value which you're seeing in front of you, where calcium level is low, phosphorus level is low, alkaline phosphatase is high, PTH is high, 25 hydroxy vitamin D is high, 125 hydroxy vitamin D is high, and urine calcium is not very significant. What is this? Which would you diagnose this as? This is a concept that I see a lot of people have a confusion with it, and that is why I've included this. Even in the group, when I've asked 2 questions on types of rickets, most of you answered it wrong. So I thought I'll just brush on this concept a little bit and make you understand how to remember this in an easy way. Anyone who'd like to attempt this question? There's high chances of this coming in the INI-CET exam. Anyone would like to give it an attempt? A guess, perhaps? No answers? Okay, we'll explore the concept. Let's understand the concept, and then I'll come back to you and I'll ask you the same question again. So we know that the types of rickets are, okay, someone says it's D. Okay, Shabir says it's D. Okay, good guess. Any other guesses? Anyone else would like to guess? Okay, so types of rickets are vitamin D deficiency rickets, that is mainly nutritional. Vitamin D dependent rickets, type 1 and type 2. vitamin D resistant rickets, and renal osteodystrophy. And let's understand what happens in each of this. Okay, Mariam also says it's D. Okay, we can wait for more answers, but I'll keep telling you the concepts. Meanwhile, you can keep answering in the chat box. So in nutritional rickets, the problem is dietary deficiency of rickets. So what happens is there is reduced calcium and reduced phosphorus in the diet, and when there is reduced calcium also, there is also reduced 25 hydroxy vitamin D. Even this will reduce in the body, and also 125 hydroxy vitamin D also will reduce in the body. So what happens is calcium and phosphorus is less, so in the blood also there will be reduced calcium, and when there is less calcium in the blood, it will activate this gland called as parathyroid gland, and that will secrete more parathyroid hormone. Now this parathyroid hormone has three important functions, two in the kidney, one where it goes to the kidney, another near the renal tubules, and third one at the bone, and I'll tell you three of these. The first one, what it does is it will convert 25 hydroxy vitamin D to 125 hydroxy vitamin D, which is the active form of vitamin D. This is the active form of vitamin D, very important. Okay, second thing is it will reabsorb calcium from the urine, and it will let phosphorus be excreted in the urine. So your urine will be high on urine phosphorus will be high. Urine phosphorus will be high, and calcium is getting reabsorbed back. The third thing is it will also cause resorption of the bone. So there will be bone resorption. And because of bone resorption, calcium will be restored in the blood. And also, when there is bone resorption, ALP markers have to increase, because ALP, bone turnover marker, ALP. So ALP will also increase. Now let's understand the function of active vitamin D. This active vitamin D also will act on bone resorption. Also, it will go into the intestine and increase absorption of calcium and phosphorus into the blood. So now what is happening? The lab values of nutritional rickets. Calcium may be normal or reduced after the correction. Phosphorus may be normal or reduced after the correction. ALP will be high. Parathyroid hormone will be high. 25 and 125 hydroxy vitamin D both will be low. Urinary calcium will be normal, and urinary phosphorus will be high. Okay, is this understood? Is this clear? This is what will happen in nutritional rickets. So you have to remember this cycle in nutritional rickets. Now, what is the differences that you see in vitamin D dependent rickets? So focus on the word vitamin D dependent rickets, meaning it is dependent on vitamin D. Now, what is happening wrong in vitamin D? Here, the diet is normal. There is normal dietary intake of vitamin D. It goes in, it gets converted to 25 hydroxy vitamin D, but then later in the kidney, there is deficiency of 1-alpha hydroxylase renal enzyme, and this will prevent it from getting converted from 25 hydroxy vitamin D to 125 hydroxy vitamin D. So there is no active metabolite that is getting formed, and that is the main problem in vitamin D dependent rickets. That is, 1-alpha hydroxylase enzyme is deficient, resulting in less active form of vitamin D. So if you look at the lab values, what will you see? You will see that there is high amount of 25 hydroxy vitamin D that is getting secreted, high amount of 25 hydroxy vitamin D, but there is decreased amount of 125 vitamin D. So how will you remember this? Remember that in vitamin D dependent rickets, you should always look at vitamin D components, both active and inactive. In vitamin D type 1, only one criteria is increased, that is 25 hydroxy vitamin D. So in the chart, if you see only one criteria increase, tick type 1 vitamin D dependent rickets. Now what happens in type 2 dependent rickets? Here, no, everything is going right. They are secreting active metabolite of calcitriol, but this calcitriol is not able to go into the end organs and act because of FDR, vitamin D receptor insufficiency, so VDR gene abnormality, insensitivity. Okay, there is a receptor insensitivity, because of which this active metabolite is not able to act on the end organ. So there is end organ insensitivity. So here what will happen? Here both forms of vitamin D are secreted in large number, but they are not going into the end organ. So here both the criteria are increased. So vitamin D dependent rickets type 2, both types of vitamin Ds are increased. Is this understood? Okay, it's increased. Okay, fine. So next comes renal rickets. Next comes the vitamin D resistant rickets, so which is also called as renal rickets. Okay, what happens here is your kidney is the problem. Your renal tubules are failing you, and because of that, they are not able to absorb phosphate. So there is a lot of phosphate that is getting lost in the urine. So there is loss of phosphate, and that is resulting in defective mineralization. So what is happening in vitamin D resistant rickets is that there is no problem in vitamin D metabolism. That is why it is called as vitamin D resistant rickets. Vitamin D is not the culprit here. The culprit is renal tubule. So it is a renal tubular rickets where the kidney is the problem. Kidney tubules are failing in reabsorbing phosphate. They are not able to reabsorb phosphate. Correct, Purni? You talk about phosphorus here. Phosphate is not getting reabsorbed, and because of that, there is increased urinary phosphate. And what is happening in the bone? See, we are under the conception that only calcium is important for the bone, but even phosphate is important. If you want any kind of bone structure being formed, you need phosphate as well. So if there is reduced phosphate, that will also result in defective mineralization. So what is happening here? Here the calcium level is normal, phosphorus level is low, ALP is slightly increased, PTH is normal, vitamin D, both the types are normal, they are untouched. Urinary phosphorus, what is happening to urinary phosphorus? It is increased a lot. Okay, so this is how you will diagnose. If you see urinary phosphorus has increased a lot, then you know that it is vitamin D resistant rickets. It is vitamin D resistant rickets. Now the last type of rickets. So you understood till here? Please bear with me for one more concept, that is renal osteodystrophy. So in renal osteodystrophy, there is failure. There is kidney failure, there is renal failure, and because of renal failure, 1 alpha hydroxylase is not there. 1 alpha hydroxylase is not there. That is why vitamin D also is not getting secreted. If vitamin D is not getting secreted, there will be reduced calcium. Now if there is reduced calcium, parathyroid hormone will increase, and also ALP will also increase. Now one more problem, because kidney is failed, is that phosphorus is now not getting excreted. It is getting reabsorbed. Their excretion is stopped. So what will happen? The amount of phosphorus in the blood will increase to a lot. Okay, so this is the renal osteodystrophy complaint. Now because of this increased parathyroid hormone, which has nowhere to act because kidney is failing, there will be a lot of bone resorption, and that is why you get all of those signs of Ruger jersey spine and all the other features of resorption of bones in all parts of the body. Okay, but let's understand the laboratory findings here. The one unique finding is phosphorus is increased. So in renal osteodystrophy, one finding that you have to search for is phosphorus has increased. So renal osteodystrophy is renal failure patients, deficiency of vitamin D, decreased calcium, but high phosphorus level. So now I'll tell you the trick how you'll remember all of them. So you know how nutritional rickets is, you know the normal mechanism. Then for vitamin D dependent rickets type 1, look for the vitamin D components, this and this component. If only one component is high, it is type 1 rickets. If both components are high, it is type 2 rickets. If urinary phosphorus is much higher than anything else, then it is vitamin D resistant rickets or renal tubular rickets. If serum phosphorus is very high, then it is renal osteodystrophy. Is this clear? Have you understood this? Now let's go back to the question, and I want you to tell me the answer now. I want all of you to tell me the diagnosis now. What do you think is the answer here? So because understanding this concept is very important. Now that you understood the concept, can you revisit the question and tell me what is the answer? Shabir, correct. Yeah, it's C. So because both these factors are elevated, it is type 2 vitamin D rickets. Yes, correct, Ashutosh. It is C. Correct. I hope you all understood this. Okay. So this is very important. This can be a concept they can ask you in the INI-CET exams. Okay. So the answer is vitamin D dependent rickets type 2. Now this type of questions are very common. Last year they asked a question about foot drop, and they had marked structures, different nerves, and they had asked which site would there be an injury most probably. The answer was neck of fibula. So these kind of questions you can expect, where what they'll do is they will give you an injury, a fracture, and they will give you the nerve involved, and they might ask you one of the two. They might ask you what is the nerve involved or what is the injury that has happened, and also they might give you an anatomical picture. So look at this question here. Which of the following nerve is injured in a fracture called as Holston-Lewis fracture? And they've given markings here. They have not given you the direct nerve. They've given you markings. It is D, C, A and B. Anyone would like to answer this? Even if you tell me which nerve is involved, I'll be happy. Okay. Ashutosh has done just that. He's told me which nerve is involved. Okay, Ashutosh, would you like to try this labeling as well? Which label do you think is radial nerve according to your answer? Yes, Shabir says it's C. Anyone else? See, you can expect one question like this, definitely. A question where they'll test three things. They'll test your anatomy skills, they'll test your knowledge of eponymous fractures and associated nerve injuries. Okay, yeah, Shabir has again clarified it that the option is B. Okay. Okay. Yeah, that again is where you can get confused. You might look at the answer and you might mark that as the option. So that is one thing. Okay, so Holston Lewis fracture. I'll tell you a little bit about Holston Lewis fracture. So these two gentlemen are Holston and Lewis. So they noticed that in most people who had lower third humerus shaft fractures, spiral humerus shaft fractures, many of them came with wrist drop. They came with wrist drop. And when they inquired further, they realized that what actually we see is this type of fracture, but what we don't see is that there is a nerve entrapment along with that fracture, and that nerve that is getting entrapped is the radial nerve. And that is why this fracture came to be known as the Holston Lewis fracture. That is, fracture of the distal third humerus, spiral fracture with entrapment of the radial nerve. So all of you were right. Ashutosh was right. Mariam C. Yeah, that is also right. Shabir, all of you are right. It is radial nerve. The answer is radial nerve. And if you want to know the anatomy, I'm pretty sure all of you know this was the radial nerve. So the option that you had to mark, the option that you had to mark was B. So it was B. Okay. So I'll go a little bit more further. I'll tell you a little bit about Holston Lewis fracture. So the features of Holston Lewis fracture, you will see posterior arm sensation is spared because PCNA is intact. Extension at the elbow is also spared. Triceps is spared. The only thing you will see is wrist and finger drops and sensory loss at the first web space. And how do you treat humerus shaft fractures with radial nerve palsy? This can also be a question they might ask you. See, if just because there is nerve injury, you don't have to go and surgically fix this, because most of Holston Lewis fractures are neuropraxic injuries. Neuropraxic injuries will heal on their own. You give it time, it will heal on its own. So what you do is you treat them like any other humeral shaft fractures, and then you ask the patient to come after 3 months. After 3 months, if recovery is there, all well and good. If there is no signs of recovery, then you might have to do a nerve conduction study. And in nerve conduction study, if there is no signs of recovery of the nerve, then you might have to go for nerve exploration. So please remember this algorithm to treat cases of nerve in humeral shaft fracture with nerve injuries. Okay, they can ask you this as a concept as well. And also for all the other questions they might ask you, there are a lot of possibilities. So out of all of this, they can ask you one question. They can tell you that there is an anterior shoulder dislocation. Which nerve is involved? The answer is axillary nerve. Then there is surgical neck fracture. So please note down this chart. I'm not going to tell all of these in detail. Please note this chart down. They can ask you a question on any of this. It has been asked frequently. At least 3 times they've asked this fracture nerve involved, and they've given a diagram and they've asked you what is the treatment. So please expect a question like this in your coming exams. Okay. Okay, so one piece of advice or just a humor for you is 1 week before the INI-CET, you'll have so many things in your head. You'll have so many things to do, 19 subjects to revise. But please remember that don't go to study everything from scratch. Be prepared now only that you make a kind of revision copy which you will refer 1 week before the exam, because it is not possible to cover everything before an INI-CET exam. It is very important to note down high yielding topics, write them down in a different book or make note of it, or keep it bookmarked somewhere, and in the last 4 to 5 days just refer to them. Okay, otherwise your condition will be like this going into the exams. Now coming to nerves, they usually ask a test and they'll ask you about the nerve. I've gone a step further. I've asked you the nerve injured and also the muscle involved, because this is INI-CET exams. Okay, so identify the nerve and the muscle action being tested in this. Your options are ulnar nerve and dorsal interossei, median nerve and flexor pollicis longus, median nerve and adductor pollicis, ulnar nerve and adductor pollicis. Anyone? You can tell me which, if you know part of the answer also, it's fine. You can tell me which nerve is involved, or if you know what test it is, you know the name of the test, that also is fine. Or if you know the muscle also, anything, any part of the answer, any way you can contribute to this discussion is welcome. Okay, Shabir says it is D, ulnar nerve and adductor pollicis. Anyone else with an answer? Okay, Sakshi also says it's D. Okay, any other answers? Ashutosh says it's Fromensis. Yes, Ashutosh has covered everything now. So Fromensis and the answer. Okay, all are right. So the answer is ulnar nerve, and the reason I've included this is because people get confused between ulnar nerve and median nerve. So if you want to remember all the muscles that the ulnar nerve supplies, I've made a simple chart. Just this one diagram will help you remember all the muscles, and you won't get confused between median and ulnar nerve. So we know that in ulnar nerve, 1.5 flexors, that is flexor carpi ulnaris, and medial half of FDP is involved, and adductor pollicis is the only thenar muscle that the ulnar nerve supplies, and then all hypothenars, all four interossei, and third and fourth lumbricals, these end lateral lumbricals, these third and fourth lumbricals are supplied by ulnar nerve. How do you differentiate that from ulnar medial nerve? Medial nerve has this supply. It has pronated teres, all the flexors except FCU and medial half of FDP, and all thenar muscles except adductor pollicis. Okay, so now let's look at tests of the ulnar nerve. So ulnar nerve test can be different. One is ulnar claw hand. What happens is, because the third and fourth lumbricals are damaged, the function of third and fourth lumbricals is to flex the metacarpal and extend the interphalangeal joints. But if they are damaged in the third and fourth area, that will result in clawing in the third and in these two fingers. This is called as an ulnar claw hand. This is used to test lumbricals, not to test any other muscle. It is used to test lumbricals. The test that is done to test for the test that we do for testing adductor pollicis is Froment's or book test. These are the two tests, Froment's or book test. So in, you ask the patient to hold a card or a book. If he is able to hold it flat like this, that means his adductor pollicis is working. But if he is bending his thumb, if it is like this, then it is not the function of the adductor pollicis, it's the function of the flexor pollicis because of the median nerve. Okay, so this is Froment's positive. This means that he has an ulnar nerve injury. Okay, so your answer was right. It was Froment's sign. Ulnar nerve was being tested. The muscle was adductor pollicis. Few other tests. Card test is for palmar interossei. Igawa's test is for dorsal interossei. And one more concept you need to know in ulnar nerves is ulnar paradox. See, what happens is, whenever there is a nerve injury, distal nerve injuries will have more clinical signs or will be more profound than proximal nerve injuries. But in ulnar nerve, there is a paradox. In ulnar nerve, when the ulnar injury is at the wrist, the clawing is more prominent. But if the ulnar nerve is at the elbow, the clawing is less prominent. This is because of the FDP function. Because FDP is not affected when the injury is at the wrist, it is affected when it is at the elbow. And that is why, because it is not following the normal rules of the nerve, we call it as the ulnar paradox. I hope this is clear. I don't have to explain this more. And one more sign that I want you to know in ulnar nerve, which I don't think a lot of educators cover, is Wartenberg sign. This is also a sign of ulnar nerve injury. Can someone tell me what is Wartenberg syndrome, so that you don't get confused between the two of them? So I'll wait for your options, but I'll tell you what Wartenberg sign is. See, Wartenberg sign, you ask the patient to keep his fingers extended and keep it on the table. You ask him to keep it on the table, and when he does that and there is an ulnar nerve injury, because interossei are paralyzed, this movement of extension and on the table is because of only extensor muscles. They're acting unopposed. These extensor muscles are acting unopposed, and because the root of this extensor digiti minimi is a slightly curved root. It is a slightly curved root. That is why you will see that an unopposed extensor acting, you will see the finger going like this. This is a Wartenberg sign. Okay, did someone tell me what a Wartenberg syndrome is now, so that you don't get confused? It is an entrapment neuropathy of which nerve? I'll make it more easier. Please don't get confused between two of them. Wartenberg sign is a sign of ulnar nerve injury. Okay. Wartenberg syndrome is an entrapment neuropathy of the no answers. It is the entrapment neuropathy of superficial radial nerve. Superficial radial nerve. Yes, it can be called chiralgia paresthetica also. It is the superficial radial nerve that is getting injured. Okay, is getting entrapped. So the answer here is ulnar nerve and adductor pollicis. Now this is a question asked in last year's INI-CET exam. Which structures are injured in the following condition? And I'm pretty sure we've not covered this in our normal syllabus. So I've put it up here so that we can try to answer this. Which structures are injured in the following condition? Is it acromioclavicular ligament? Is it coracoclavicular ligament? Is it coracohumeral ligament? Or is it both acromioclavicular and coracoclavicular ligament? Let's look at the X-ray. I'll zoom into the X-ray here. So let's try to mark what structures we know, then we'll go into the injury. So I know that this is a clavicle, I know that this is an acromion, I know that this is coracoid, this is coracoid, and this is the humeral head. Now, do you see any abnormality in the X-ray? Anything that seems out of the ordinary? Anyone? Anything abnormal? Okay. Shabir says that AC ligament is involved. Acromioclavicular ligament is involved. Okay. I'd like you to tell me the injury first. Yeah, you are right. Acromioclavicular ligament is injured. It's involved. Correct. But the injury, do you know what type of injury this is? So we discuss about shoulder dislocation, elbow dislocation, hip dislocation. You also need to know about one more criteria, one more injury called as AC joint dislocation. There is something called as AC joint dislocation where the clavicle just goes above, it goes upwards. It is an AC joint disruption. Now, Shabir, why do you feel that only acromioclavicular ligament is involved? Because if you go back to your anatomy, I'll go back to your anatomy, and if you see the structures around the shoulder, you will notice that to hold the clavicle in its place, it is not just the acromioclavicular ligament that is responsible. There is also the coracoclavicular ligament that is involved. Okay, I'll erase this and I'll show you an animation. So what happens exactly in that X-ray? If you had to, so what happens in that is two injuries. Can you see here? This is what has happened here essentially. There is damage of which ligament is this? It involves the clavicle and coracoid. So it is coracoclavicular ligament. And there is injury here also, that is AC joint injury. So acromioclavicular ligament is also injured. Now you can go back and tell me what is the option, what is the answer here? Is it only acromioclavicular ligament? See, it is both acromioclavicular and clavicular-coracoid ligament or coracoclavicular ligament. Okay. So yeah, D is the answer. Correct, Soumya. So I hope you understood this. This was something that was asked last time as well. It was asked in a previous exam about acromioclavicular joint dislocation. Now, because that was asked, I thought I should also tell you a little bit more theory about AC joint dislocation. I want you to remember two important MCQs in AC joint dislocation. One is the preferred view. Whenever you want to check X-rays of AC joint dislocation, what X-ray view will you do? The answer is Zanka's view. Z-A-N-C-A. Zanka's view is the X-ray that is preferred for AC joint dislocation. That is one. And second, you have to remember the classification. The classification is Rockwood's classification. It is the Rockwood's classification. I hope, please remember these two, just note them down, because question was asked in AC joint dislocation. This time they might ask you a different question. That is why I've given you two important MCQs from AC joint dislocation. Okay. So now again, a little bit of advice. The advice is, again, I've told you before also, plan your INI-CET revision. Don't be like this person. Don't think of planning it later, or don't postpone it. Plan your INI-CET revision now only. The last 1 week, what you're going to be doing, every hour should be planned out immediately so that you can get better results, because that 1 week is going to be a big decider on your rank. So always make plans for your INI-CET revision. Okay. Now let's go into another question. This is a kind of modification from a previously asked INI-CET question. A 45-year-old man with diffuse back pain and chest tightness, X-ray imaging is done. What is the diagnosis? The options are DISH, ankylosing spondylitis, Sprengel shoulder, and Klippel field syndrome. Correct, Purni Shetty. The answer was both AC and CC joint. You're right. It's correct. Now let's focus on this question now. I'll zoom into the X-ray. I'll show you the X-ray in detail. Good evening, Dr. Arpit. Welcome to the session. Okay, Ashutosh tells me the answer is B. I'll just show you the X-ray for 5 seconds. I want all of you to see this X-ray very carefully, because the diagnosis is based on the X-ray. Clinical features are not going to help you get the diagnosis. The X-ray is going to help you get the diagnosis here. Anyone else would like to give a guess? Or do you agree with Ashutosh that it is B, ankylosing spondylitis? If you want me to zoom in on the X-ray again, I can do that. Please let me know in the chat box. Anyone with any other answers? Shabir, what do you think is the answer here? Soumya, what do you think the answer is? Okay, okay, fine. All right. So the reason I've included this is because it's a little tricky question. And this has been asked previously. So Ashutosh says it's ankylosing spondylitis, and I get your point of view here. But let's understand what we're dealing with. So first, let's understand about cervical spine, normal X-ray and anatomy. So we know that we have C1, this ring structure that is there here. This ring structure is C1. This is C2, C3, C4, C5, C6, and C7. This is the spinous process. These are all the joints. And ideally, if you look at this anatomy here, ideally anteriorly you will have the anterior longitudinal ligament. Here posteriorly you will have the posterior longitudinal ligament. And in between these spinous processes, you will have interspinous and supraspinous ligaments. And also ligamentum flavum. Okay, so that is how a normal cervical spine should look. Then obviously there are trachea and other things, not important from an orthopedic point of view. But these things are important for you to know. Now, so this is the labeled anatomy. I hope this much you know. You know this normal cervical X-ray, how it looks, what is there in the spine, these structures you know. If you know this, let's build our concepts further. Let's understand each of these diseases. First one is Sprengel shoulder. So see, Sprengel shoulder is when there is no descent of the scapula. What happens in the scapula is by 5 weeks of gestation, the scapula is at this level, that is at level 3. And by 12 weeks of gestation, the scapula will descend downwards. This is normal. This is seen in everyone. There will be descent of the scapula downwards. But if there is absence of this descent, either because of some kind of bony union, some kind of omohyoid bar, or it can be because of general, there is no pathway that is allowing it for descent, that will result in a high riding scapula called as Sprengel shoulder. So Sprengel shoulder is something different. It is a high riding scapula. Next, let's talk about Klippel-Feil syndrome. What is Klippel-Feil syndrome? In Klippel-Feil syndrome, see, normal cervical spine looks like this, where you have C1, C2, C3, C4, C5, C6, C7, and between them, you have these discs. Between C1 and C2, between C2 and C3, C3 and C4, all of the areas you have discs. But in Klippel-Feil syndrome, there is absence of segmentation. There is failure of segmentation of these cervical vertebrae, because of which some of the cervical vertebrae may be fused. As you can see here, these cervical vertebrae are fused. There is no disc in between them. And that is Klippel-Feil syndrome. And because of Klippel-Feil syndrome, you will have a triad. The triad is low hairline, short neck, and reduced range of motion at the neck. Neck range of motion will be reduced. So that is Klippel-Feil syndrome. Okay. Ankylosing spondylitis is another condition that is an inflammatory condition, an autoimmune inflammatory condition, where the main structure that is involved is an enthesis. What is an enthesis? It is the end segment where a ligament is attached to a bone. Wherever the ligament is attached to the bone, that area is enthesis, and this enthesis will undergo inflammation. So what will happen is there will be an autoimmune attack leading to enthesitis, inflammation of the enthesis, which will later result in erosive lesion, which will later form a fibrous ankylosis, which will later form a bony ankylosis, and last there will be ossification of the ligaments, and finally the spine will become like this. The whole spine will start to get ossified. Okay, that is ankylosing spondylitis. In a way, it is us going backwards in evolution. Okay, there will be, you will have a stoop, you will have less range of motion of the spine, there will be some severe restriction in breathing, in movements, all of that. So that is ankylosing spondylitis. Now what is dish? That was one of the options. Now what is dish? Is it dish TV we are talking about? What is the full form of dish? See, DISH stands for a condition called as diffuse idiopathic spinal hyperostosis, which is a flowing wax ossification. What happens is the ALL, I talked about anterior longitudinal ligament, that will start to get ossified. There is a flowing wax ossification of anterior longitudinal ligament, and this has to be in at least 4 contiguous segments. Okay, understood? In dish, there is only ALL that is getting ossified, but in Angst-Pond, everything is getting ossified. All the ligaments, be it ALL, PLL, annulus fibrosis of the disc, interspinous ligament, supraspinous ligament, all of them are getting ossified. So the main difference in ankylosing spondylitis and dish, I won't discuss all of this, you can take down a screenshot of this, but the main thing I want you to know is that in dish, intervertebral discs are spared. SI joint is not involved, but in ankylosing spondylitis, everything is fused. Sacroiliitis is fused. Also, there is, yes, correct, Abhirami ma'am, it is diffuse idiopathic spinal hyperostosis. Thank you for contributing. So, in ankylosing spondylitis, there is intervertebral joint fusion, there is SI joint that is fused, there is ossification of the disc space and everything. Okay, so do you understand the main difference between dish and ankylosing spondylitis? Ashutosh, do you understand the difference now that what is dish, what is ankylosing spondylitis? So now I'll ask you this question again. I have 4 x-rays here and I want you to diagnose all of these x-rays based on the concepts that I just told you. I'll start with the easier one. Let's mark this as A. What is the diagnosis of this x-ray? Look at the scapula. So can you see that the scapula is here and one scapula is here? Sprangle, correct. Shabir, it is sprangle shoulder. So this is fairly easy. It is sprangle shoulder. Now I'll go to the second x-ray. Let's look at this x-ray here. What is the diagnosis in this x-ray? Yes, Soumya, you're right. That was sprangle shoulder. Now B, x-ray B. What do you see here? Angstpon? No, no, Ashutosh, I want you to, whenever you see an x-ray of cervical spine, I want you to see the disc. Can you see here? Discs are intact here. It's not like the whole spine has become a bamboo spine. There is no whole spine that is fused. Only there is fusion of these two vertebrae, there is fusion of these two vertebrae, and there is no disc in between them. Can you see? These two areas are fused. I'll erase that. Yeah. Klippel field, correct. Yeah, see, I want you to focus on the intervertebral discs. I want you to focus on ALL. See, there is no ALL ossification, so it is not dish. Angstpond also it cannot be because you can see some discs are still intact. Only thing you can see is congenital fusion of few vertebrae. So this is Klippel field syndrome. Okay. Now this one. Okay, let's mark this as C and also D. I want you to see both of them and tell me which is dish, which is Angstpond. Use everything that I've told you till now. Use the concepts that I've told you. Is which is Angstpond, which is dish. Shabir says C is Angstpond. Shabir also says D is dish. Ashutosh, yes, Ashutosh has now come to track as well. He says C is Angstpond. Sakshi says C is, yes, correct. So now you understood the concept that this is Angstpond because here even the discs are not spared. And can you see the spinous process? I can't even see the spinous process because the whole area is fused into one. It has become a bamboo spine type of structure. So this is Angstpond, and here can you see only the ALL is fused, and this is more than 4 segments. So this fusion is a candle wax flowing ossification. So it is dish. Yes, Samya, you're also right. Angstpond. C is Angstpond and D is dish. Is that concept clear? Have you understood what to look for? You have to look for the discs, intervertebral discs. You also have to look for whether there is fusion of the congenital vertebrae. Then you'll be able to differentiate between these 3 things: dish, Angstpond, and Klippel field syndrome. Okay. So now if you go back to the question, you will see even in this there is discs are preserved. Can you see here? Discs are preserved, Ashutosh. The discs are preserved here. So this is a case of dish. And another clue, if you wanted from the clinical findings, it is elderly patient, 45-year-old elderly patient. Usually dish is seen in elderly patient. Angstpond is usually seen in a little more younger patient. Okay. So this is how you will decode a case of dish, Angstpond, and Klippel field syndrome. And few other features, I won't go into this. In ankylosing spondylitis, sacroiliitis, dagger spine, bamboo spine, and MRI wise you will see shiny corner sign, which is a Romanov's lesion and Anderson lesion. So these are all features. And one more thing I want you to remember in Nang's-Pont is modified New York criteria, where clinical criteria are low back pain and stiffness, limitation of lumbar mobility, and reduced chest expansion. Radiological criteria is only one. No spine involvement, only sacroiliitis. That is a definitive criteria. Okay, that is how you will diagnose ankylosing spondylitis. Now let's go into another spine question. A man underwent a spinal surgery 1 week back and his post-operative x-rays are shown below. The screw inserted are fixed through which structure? So I'll show you this x-ray here. This was a spine surgery. This is an x-ray of our hospital. Can you tell me what these screws, you can see, these are all screws here. There are 6 screws here. On which structure are these screws put at? Are they lamina, pedicle, spinous process, transverse process? Okay, Shabir says it's pedicle. Any other answers? Anyone else? What do you think it is? Okay. This is a question that has been asked previously in one of the exams. So for this, you have to first understand the structures of the spine. So in the spine, this is the vertebral body. This here is the pedicle. This is the transverse process. This is the facet. This is the spinous process, and this is the lamina. And also a disc in between the intervertebral segment. Now you have to understand a concept called as Dennis 3-column concept. This is very important in spine. See, whenever you have any spinal injury, you should be able to differentiate them into stable and unstable spinal injury. And for that, you have to first understand this Dennis 3-column concept. Dennis says that spine can be divided into 3 columns, that is anterior, middle, and posterior column. Anterior column is this much, which has ALL, anterior annulus, and anterior 2/3 of the vertebral body. Middle column has posterior 1/3 of the vertebral body, posterior annulus, and PLL. Posterior column has posterior ligaments, pedicle, facets, lamina, and all of them. He says that if there is injury to only one of the segments, one of the columns, then it is a stable injury. But if injury is to more than one column, then it is an unstable injury, and in unstable injury only we will do surgery. So for this case also, it was an unstable injury, and that is why we've done a surgery. So when we do a surgery, we always see to it that we put an implant across at least all 3 columns or at least 2 columns. So how can we do that? How can we go to all 3 columns with an implant? That is through a pedicle screw, by using a pedicle screw. So you can see the animation here. Look at this animation here, how we are making a hole using a probe. We are making a hole through the pedicle going into the vertebral body. Then we are checking whether the hole is correct, medial and lateral wall is intact, and then we'll probe it, and last we'll put a pedicle screw. So can you see here, we put a pedicle screw, and this pedicle screw is going from the posterior element, middle column, anterior column. So it is holding all 3 columns, and that is why you'll get a good fixation. So please remember, in spinal surgeries, the only screws that we put are pedicle screws. These are the most important screws. Pedicle screws are used normally. Okay. Next, moving to the next question. A patient has difficulty climbing upstairs. When he was made to bear weight on the right lower limb, the pelvis of the left side dropped down. Which of the structure involved causes this problem? Is it right superior gluteal nerve, left superior gluteal nerve, right inferior gluteal nerve, and left inferior gluteal nerve? So this question is from a concept of Trendelenburg test and Trendelenburg gate. Okay, Shabir and Ashutosh are very quick with their answers now. So they say it is right superior gluteal nerve. Okay. Anyone else would like to try? Okay, yeah, Shabir and Ashutosh, you're right. Yes, Sakshi, you're right too. Well done. So Trendelenburg gate and test is the concept that is being tested here. What is it used for? It is used mainly to look for weak abductor muscles due to any cause. It can be any cause, but weak abductor muscle. Let's understand a little bit what Trendelenburg gate is. See, normally we have this lever mechanism in both the hips. Now, if we shift all our weight to one leg, imagine you shift all your weight to one leg, you'll notice that normally the pelvis will stoop downwards. It will go downwards in the opposite side. As you can see in this animation now, you will see that the pelvis will now stoop downwards. Yes, see, can you see that? It's stooped downwards on the opposite side. But this is prevented by our abductors. Our strong abductors on that side where we are bearing weight will pull the pelvis back, and it will level the lever mechanism. It will not allow it to shift. It will maintain an equilibrium and your pelvis will be balanced. If your abductors are normal on the opposite side, it will not sink downwards. Okay. So what will happen in Trendelenburg test? What we'll do is, see, this side which you're checking, will mark that as unsound side. This is the sound side. Okay. So if you think that this side there is some injury to the abductor, now what you will do is, first you'll ask the patient to stand on the sound side. Now look, is his pelvis drooping downwards? It is not. It is not drooping downwards. Then you ask the patient to stand on the unsound side, and when he stands on the unsound side, can you see how the sound side is stooping? Sound side is stooping or falling down, and this is the Trendelenburg mechanism, where if your abductors on this side are not normal, then your hip pelvis, when you make the patient stand on the unsound side, pelvis will stoop towards the unsound side. Okay, it's towards the sound side, sorry. Okay, sound side. So just remember this SSS, sound side sinks. This is the mnemonic you have to remember. Okay, I think you all know what the Trendelenburg test is. So let's go back to that question. So here they are telling you that the pelvis drops to the left. So left is the sound side, right is the unsound side. So right it is. Then we have to know which are the nerves involved. See, the main muscles in Trendelenburg gait are gluteus medius and minimus, and they are supplied by superior gluteal nerve. So it has to be right superior gluteal nerve. So the answer is right superior gluteal nerve. Okay, did you understand how to arrive at the diagnosis? Now another question, a variation of a Trendelenburg gait question. This was asked a few years back. Patient standing on one side has Trendelenburg sign positive. What is the action of the muscles tested in Trendelenburg test? They're basically asking you, what is the action of gluteus medius? Is it abduction, flexion, adduction, internal rotation, or a combination of those? Anyone would like to try this? Okay, Shabir says it's one only. But Shabir, it's not only abduction that is gluteus medius is involved in, it is also internal rotation. So the answer is 1 and 4. I knew there would be a little confusion here. That's why I put this question out. If this question comes in the exam, it's not just 1, okay? It's 1 and 4. Abduction and internal rotation. Alright? Yeah, Soumya, you're right. It is 1 and 4. Abduction and internal rotation. You're correct. Now, till now, questions have been asked in pediatric orthopedics from only one topic, that is CTEV. So we'll discuss a little bit about CTEV. A newborn child is diagnosed with CTEV and sent to the orthopedic surgeon for treatment. Which of the following is true? Listen to the options carefully. Turco's operation is done to correct this deformity. Ponseti technique is used to correct the deformity, with fulcrum of the correction being calcaneocuboid joint. Cavus adduction and varus are corrected by Ponseti maneuver, and equinus is corrected by tenotomy. Ponseti technique is ideally started 2 months after birth. So we have 4 options here. Which of this is correct? See, you can tell me which are wrong also. If you feel like some options are wrong, you can tell me those. We can start ruling out the options first. Which options do you think are absolutely wrong? Any answers? Anyone can contribute to this discussion? Is CTV not studied? Okay, I'll start discussing a little about the concepts of CTV, and then C is wrong. C is wrong. Equine is also corrected by Ponseti. Okay, Shabir feels that C is wrong. Okay, okay. Anyone else feels any options are wrong? Okay. So what is there in CTV? The deformities are important in CTV, and also in which zone of the foot is also important. So we know deformities by this mnemonic cave. Everyone, if you ask them, they'll tell cave, cavus, adduction, varus, equinus. But also remember which zone of the foot is involved. Equinus and varus is seen in hind foot, cavus is seen in midfoot, and adduction is seen in forefoot. And the joints are also important. So please remember this table of CTEV, which joints are involved and which zones of foot are involved. Now, treatment for CTEV, before we used to use Kite's correction, where the fulcrum was calcaneocuboid joint. That is, we used to keep a finger at calcaneocuboid and then do the correction. But now we've changed to Ponseti correction, where we keep the finger, the fulcrum, at the talus. So talus is the fulcrum. So we can rule out this option. This is wrong because fulcrum of correction is calcaneocuboid. No, it is talus. Okay. Then next one, Ponseti manipulation. See, Shabir, I'll tell you what is Ponseti manipulation. In Ponseti manipulation, we have Dr. Ponseti said that soft tissues are very malleable. In children, soft tissues are like clay. They can be molded and they can be corrected, and that is why he told that we can correct cavus, adduction, and varus using this manipulation technique. Ponseti himself said that using this technique of manipulation, we can correct cavus, adduction, and varus. But equinus, this tendo Achilles that gives equinus, no, that cannot be corrected because that is very rigid structure. That cannot be corrected by this manipulation, and that is why we have to do tenotomy. Although Ponseti himself has introduced tenotomy, but it is not a manipulation technique. You have to take the patient up to the OT and do the tenotomy. So equinus is only corrected by tenotomy. Ponseti's maneuver or manipulation cannot correct equinus. Is this understood, Shabir? So tenotomy is done to correct equinus, and that is why in Ponseti cavus, adduction, varus is corrected, and by tenotomy equinus is corrected, and then you apply POP, above knee POP, which you keep changing every week repeatedly. Okay, this is what is done in normal Ponseti's technique. So this option is actually correct. This option is actually correct. Now, what is wrong with option A? Can we do Turco's procedure in a child who is just newly born? Let's find that out. Let's understand what is normally done in, okay, in newly born children. We do Ponseti's technique, we do tenotomy, and after that, till the child learns to walk, we'll use Dennis Brown splint. This is the splint that we'll use. Or nowadays we've started using Stenbeck's foot abduction brace. I hope you take note of this because it's something recent, something very commonly being used, so examiners might pull it up as a question. Stenbeck's foot abduction brace is used nowadays. And afterwards, as the child starts to walk, we'll use this CTV shoe or Dennis Brown shoe. So this is the shoe. I won't go into the details of that. But if the same child comes to you, yes, Soumya, you're right. If the same child comes to you at 1 to 3 years, what is the problem? Now your leg is not like clay. You cannot mold it because patient will start getting soft tissue contractures by 1 year, and that is why you'll have to release those soft tissue contractures. You have to do a posteromedial soft tissue release where you release tendo Achilles, where you release tibialis posterior, flexor digitorum longus, flexor hallucis longus, and this operation is called as Turco's operation. So Turco's operation is done in any child after 1 year. When they come for CTV correction, you'll have to do a soft tissue release. But if the child comes to you after 3 to 5 years, then just soft tissue release is not enough, because now even bone is starting to become permanent. There is forefoot adduction is now starting to become bony, and that is why you will have to do some kind of procedure to release this forefoot adduction, which is called as Dillwyn-Evans procedure, where you do calcaneocuboid fusion. You do calcaneocuboid fusion, which will give you some kind of release medially, and that is helpful in correction of CTV. But if the patient comes to you after 5 to 8 years, even the varus, even this calcaneum varus will become permanent. For that, you have to do calcaneal osteotomy called as Dwyer's open wedge osteotomy, because you have to correct this varus deformity as well. But if the patient comes to you after 8 to 10 years, no correction is possible. You have to do a wedge tarsectomy, which is a kind of salvage procedure. And about 10 years, you have to do triple arthrodesis. This is the concept that we follow. Yes, Soumya, you're right. Dillwyn-Evans procedure is done in those cases. Triple arthrodesis is done after 10 years. Okay, so we've understood this. Let's go back to the question and see what was wrong in the other options, all of the options. So here, Ponseti technique is started immediately after birth or at least 1 week later after the skin condition is good. After 2 months is not the right answer. This is wrong. Then calcaneocuboid fulcrum is wrong. Then turquoise operation is done in children of 1 to 3 years. It is not done in a newborn child. So this option is also wrong. Okay, so you understood this? Okay, now a question on open fractures has to come in every INI-CET exam. One question on open fractures is asked. So here, a patient with open wound with fracture of both bones of right lower limb comes to the emergency. The doctor, who's an orthopedician, has labeled this injury as a 3B Gustello-Anderson classification. Which of the following would represent this injury? Is it an open wound with fracture and wound less than 1 centimeter? Is it an open wound with fracture 1 to 10 centimeter but mild soft tissue injury? Or open wound more than 10 centimeter with but soft tissue coverage is not required? Or last one, open wound more than 10 centimeter with extensive injury requiring soft tissue coverage? They're basically asking you about 3B Gustello-Anderson classification. What is 3B? Ashutosh says it's D. Okay, any other answers? Or anyone else agrees with Ashutosh? Yes, Shabir says it's D too. Sakshi also says it's D. Okay. Okay, yeah. Soumya also says D. So everyone agrees that it is D. Yes. Bone is exposed, periosteal stripping. Is that correct? So I hope I'm pretty sure all of you are clear with what Gustello-Anderson classification is. I hope there is no confusion. Let's just quickly revise as to what Gustello-Anderson classification is. It is divided into 1, 2, and 3. 1 is when the wound is less than 1 centimeter. 2 is when the wound is between 1 to 10 centimeter and there is no contamination. There is no contamination and it is a simple fracture pattern. It is a simple fracture pattern. Both of them have simple fracture patterns. In 3, there is a wound with more than 10 centimeter gap and also it is contaminated and there is comminution. And some special cases where you can grade them as type 3 is when there is a farmyard injury or when there is a segmental fracture or if it is a gunshot wound. In all of these cases also, irrespective of the size of the wound, you grade them as 3. Now 3 again has a sub-classification. In sub-classification type 3A, there is good soft tissue cover. Even though 10 centimeter wound is there, soft tissue coverage is good. There is good soft tissue coverage. You don't have to do any kind of skin grafting. There is no periosteal stripping. In 3B, there is poor soft tissue coverage and ideally there is periosteal stripping. There is periosteal stripping that is seen. In 3C, there is vascular injury. Irrespective of the wound, there is vascular injury. Okay. So let's go back and try to see each of them. So A is talking about grade 1. B is talking about grade 2. C is talking about grade 3A. And D is talking about grade 3B. So you all were right. It is D. The answer is D. Now a sports injury question. So previously there used to be this trend that in every INI-CET exam they used to have questions from sports injuries. In the last 2-3 years there have not been any question, but that doesn't mean it cannot come this year. So let's see which of the following are components of O'Donoghi's unhappy triad of the knee. And they've given you these ligaments that are marked. Again, I'll focus on that. Focus on that and the options. So which of these are components of O'Donoghi's unhappy triad of knee? And they've given you these markings. They've not given you a direct structures. They've not mentioned. They've given you a marking. So here also it's a two-layered question again. You'll have to be able to identify the anatomical structure and also what this injury, O'Donoghi's unhappy triad of knee, is. Shabir says it's B. Oh, we'll do it the other way. Can you all tell me what structures are damaged in unhappy triad of knee? Then maybe we'll go into the markings. Can you tell me which structures are damaged in unhappy triad? 3 structures. We know there are 3 structures. Which are these 3 structures that are damaged? Yes, MCL, ACL, meniscus. Very good. Yeah. So MCL, ACL and meniscus is getting injured. So let's try to mark those 3 structures. So This structure which is in the anterior going cross segment, this seems like the ACL, so A is one of the options. Then this structure here, how do you know that this is medial? Because look at the fibula, this is the fibula, this is the tibia, so tibia is always on the medial side, so this is the medial meniscus, so E is one of the options. And this is the medial collateral ligament, sorry, this is medial cruciate ligament, so this is C. So it is ACL, MCL and medial meniscus. The option, the correct answer here is B. It is B. Shabir is right. It is B. Okay. So this is the O'Donoghue unhappy triad, normally seen in running athletes. When they were tackled from the side, they have this rotational injury resulting in injury to ACL, meniscus, medial meniscus and MCL ligament, and the combination injury of valgus flexion and internal rotation seen in running athletes. Okay. So this was about all the MCQs. Now let's do an interesting segment of exam leaks where I've tried to guess few questions that might end up coming in your exams. And this is not just a random guess. I've looked at what questions are normally asked and what is the pattern and how this exam pattern has evolved. So look at the first question here, because now questions will be more digital. There will be videos given. So look at the test that is being done. What is the objective of this test that is being done? Please focus on this test that is given here. You're making the patient lie down and you're asking him to flex one knee, and then you're focusing on the opposite hip and you're looking at how much flexion is there in that hip. So what is the objective of this test? And if someone can tell me what is this test also, I'll be very happy. I'll give you the options in the next slide, but please see the video carefully. So you can expect such video based questions nowadays. Anyone would like to take a dab at this? Flexion deformity. Shabir, yes. Shabir says flexion deformity, but which flexion deformity? Elbow, knee, hip. Thomas test. Correct. This is the Thomas test. Yes, Ashutosh, you are right. It is the Thomas test. See, questions have been asked about Trendelenburg test a lot. So 3 times in INI-CET, they've asked questions on Trendelenburg test. So there is a high chance that they might ask another question from hip examinations, and there is a good chance that Thomas test can be this question that they can ask. So they'll ask you an indirect question. They won't directly ask you whether it is Thomas test. They'll ask you which deformity is being tested. Is it weak hip abductors, fixed flexion deformity, limb length discrepancy, or iliotibial band contracture? I think a few of you already answered it. It is fixed flexion deformity. It is fixed flexion deformity. I'll tell you the logic of what is Thomas test. So in Thomas test, the problem with a fixed deformity of the hip deformity is they are masked. You won't get to see them directly. What will happen is this hip flexion deformity will get masked by exaggerated lumbar lordosis. See here, this patient has he has hip deformity, hip flexion deformity, but it is getting masked by exaggerated lumbar lordosis. This curve is taking over and it is masking the hip flexion deformity. So here you ask the patient to flex his opposite hip. This hip he should flex in such a way that the thigh is touching the abdomen. In such a way, if he flexes, this lordosis that is there will now become normal, and all this hidden flexion deformity will get unmasked. And then if you draw this angle, you will be able to see how much hip flexion deformity is present, and this is called as the Thomas test, where you are checking for hip fixed flexion deformity. Hip fixed flexion deformity is being checked. That is the Thomas test. So please read upon the Thomas test. Also try to read about few other things. So in weak abductors, which test do? We do Trendelenburg. This is an important test. For fixed flexion, we do Thomas test. For limb length discrepancy, we do the Galeazzi or Alice test. Galeazzi or Alice test. For iliotibial band contracture, we do Ober's test. And if possible, if time permits, please read about all 4 of these tests, because a question from hip examination can definitely come in your exams. Okay. Now coming to the next question, again a long question like an INI-CET. A 60-year-old man presents to the emergency room after an earthquake. His right leg has been trapped under his truck for an hour. Then he was extracted. He was rushed to an emergency room where aggressive fluid hydration was started. There is no penetrating injury. On physical examination, there is a large ecchymosis and abrasion on the right thigh. The right thigh is severely tender in palpation and muscles feel tense. Lab examination reveals hyperkalemia, hypocalcemia, and significantly elevated creatine kinase. what is the probable diagnosis? So you have such a long question, and please don't lose yourself in the question. Look for keywords and try to get the diagnosis. Is it compartment syndrome? Is it fat embolism syndrome? Is it crush syndrome? Or is it ARDS? Yes, Ashutosh is saying it's crush syndrome. Also, Shabir also says it's crush syndrome. Yeah. Okay. I think we'll rush through a little. I think the answer is obvious. It is crush syndrome. And please understand this concept of what crush syndrome is and why you have these lab values. Why do you get hyperkalemia, hypocalcemia, and elevated creatine kinase? Okay, so what happens in a case of crush syndrome is a patient, maybe it is an earthquake, it is an industrial injury, or it can be a landslide. Because of this, a stone or some kind of compression is there, which is lasting compression. So you can see this worker, he's been under the stone for a long period. Now, when he's under the stone for a long period, what happens is the muscles don't have any perfusion. So the muscles start to necrose. Now, this necrosed muscle will start developing these toxins like myoglobin, potassium, lactate, uric acid, cytokines. All of these will start developing in this muscle that is slowly dying. Now imagine after 2-3 hours you remove the stone out of this person and you decompress or you do an extrication. When you do an extrication or a decompression, suddenly the perfusion to those muscles are again coming back, they're regained. And when this perfusion comes back, all these toxins that are in the muscle like myoglobin, potassium, all of them will now go into the circulation. They will now start to go into circulation, and these toxins in the circulation will slowly damage the kidney, resulting in renal failure. And that is why in these patients you will see hyperkalemia, hypocalcemia, metabolic acidosis, and renal failure. Four important signs you will see: hyperkalemia, hypocalcemia, metabolic acidosis, and renal failure you will be able to see. And this is an ideal scenario of crush syndrome. Now, how will you treat crush syndrome? Because you want to dissolve or you want to saturate these toxic content, you have to give continuous IV hydration, you have to give volume expanders, you have to try to alkalize the urine, you have to correct the electrolyte balance, you have to give hemodialysis if there is severe renal failure. Also, compartment syndrome chances are there, so you have to do fasciotomy in cases of compartment syndrome because of increased compartment pressure. Is that clear about crush syndrome? Now, this is a X-ray, an eponymous fracture that I want to talk about. This I am pretty sure might end up coming in your exams, highly likely. Identify this fracture pattern. So please look at this fracture pattern. So we have spiral fibular neck fracture. Can you see that? Fibular neck, or at least proximal 1/3 fibula fracture. And also we have posterior malleoli fracture. Posterior malleoli fracture. Now, can you answer this? Is it a Malgagne's fracture, a Mason-Hughes fracture, a Hoffa's fracture, or a Plafond fracture? Shabir, Ashutosh, any answers? Anyone knows what this is? Soumya, Sakshi, Shabir, Ashutosh. I'm promising you we're coming to the end of the session. We have only 2-3 questions left. So let's try to solve all of these. Okay, so no one knows the answer here. Okay, I'll go into what these fractures are. So you have to remember all 4 of these eponymous fractures can be asked. First, I'll discuss about what is a Malgagne's fracture. Let's understand what is a Malgagne's fracture. So a Malgagne's fracture is a pelvic fracture. It is a pelvic fracture where there is injury to the ipsilateral pubic rami and also the SI joint on the same side. If pubic rami and sacroiliac joint both are injured on the same side, these are called as Malgagne's fracture. Okay, similar to Malgagne's fracture is another fracture called as bucket handle fracture. Bucket handle fracture, where the ipsilateral injury is in the pubic rami, but sacroiliac joint injury is on the opposite side. Now, why do they call this bucket handle fracture? Because the pelvis is now unstable like a bucket. That is one part of the bucket and the handle both are moving separately. That is why we call them bucket handle fractures. So Malgagny is when same side both fractures occur. Bucket handle is when different side these fractures occur. Okay, these are Malgagny and bucket handle. Okay, Malgagni fracture is a lateral compression injury fracture, ipsilateral pubic rami and SI joint fracture. Bucket handle is lateral compression fracture injury again, but here pubic rami on one side and SI joint injury on the contralateral side. Then let's talk about what is Mason-Hughes fracture. So in Mason-Hughes fracture, it is a type of pronation external rotation injury. I've covered this very clearly in ankle fractures, where I've talked about a classification called as Log-Hansen classification. Log-Hansen classification, where you can divide ankle fractures into supination adduction, supination external rotation, pronation external rotation, and pronation abduction. Okay, these four types. And in pronation external rotation, what happens is the leg is rotating externally. You can see here, leg is rotating externally, resulting in injury to, see here, medial malleoli is undergoing a transverse fracture. Then there is injury to the anterior tibiofibular ligament, and then there is an injury to the fibula much higher to the ankle. The injury to the fibula is much higher to the ankle. So this, and then last injury occurs to the posterior malleoli. Last injury is to the posterior malleoli. So here you can have tear of deltoid, transverse fracture of medial malleoli, anterior tibiofibular ligament injury, spiral fracture of fibula much above the syndesmosis. It can be somewhere in the proximal one third of the fibula as well. And last one is posterior malleolus fracture. So this is called as a Mason-Hughes fracture. Very important. Remember this. If you can't remember this whole concept, at least remember what is Mason-Hughes fracture. Okay. And what is a pillion fracture or a tibial plafond fracture? So this word plafond meaning roof. Plafond means roof. So in the ankle joint, what is the roof? This tibial articular surface is the roof. The tibial articular surface forms the roof of the ankle joint, and if that is fractured, if there is a fracture in the articular surface of the tibia, then we call it as pylon fracture or tibial plafond fracture. Plafond meaning roof is fractured, and that is what is tibial plafond fracture. Distal tibial articular fracture called as tibial plafond fracture. Okay, is that clear? Last is Hoffa's fracture, another one you have to remember. Hoffa's fracture, what happens is there's a coronal fracture of only the condyles. It can be either lateral left condyle or right condyle of the distal femur. So this is a femur. This is a distal part of the femur, and these are the condyles, medial and lateral condyle. So there is a coronal fracture of either left or right or both condyles. That is called as Hoffa's fracture. Okay. Now let me go back to the question again. Now can you answer me? Now can you tell me which fracture is this, where you can see that there is a high riding fibula fracture and there is a posterior malleolus fracture as well, and also it looks like there's some deltoid injury is there. What fracture do you think this is? Yes, Ashutosh, it is Mason-Hughes fracture. Correct, correct. This is Mason-Hughes fracture. Okay. So please remember these four high-yielding topics. That's the reason I put this MCQ here. Bucket handle, Malgagni, Hoffa's, and Mason-Hughes fracture. And if possible, read a little bit about Log-Hansen classification of ankle fractures. Okay. So this was about that. Then let's talk about, see, questions are asked commonly about DDH. Questions are commonly asked in pediatrics from CTEV. Not a lot of questions have been asked other than CTEV. So I'm predicting that a question from pediatric orthopedics might come in this INI-CET exam, and it can be not from CTEV but another high yielding topic, that is DDH, developmental dysplasia of hip. Okay, so let's understand true statements about developmental dysplasia of hip. The first statement is right hip is more commonly affected than left hip. Second one is Ortolani test is done to demonstrate dislocatable hip, and it is more preferred than Barlow's test. Cliswick sign is seen in bilateral DDH. Last one is alpha angle increases and beta angle decreases in USG findings of DDH. Yes, Sakshi, you are also right. It was B. B was the previous answer. So here again, we'll follow the approach of which do you think is absolutely wrong. If you cannot tell me which is right, tell me which sounds absolutely incorrect. B sounds, oh yeah, correct. B, Ortolani test. Okay, Ortolani test and the Barlow one, that is incorrect. Okay. Ashutosh, are you telling me B is the answer or B is incorrect? Okay, B is incorrect. Fine, fine. Okay, Ashutosh believes B is incorrect. And anyone else wants to rule out more options, or do you think, have you figured out what the answer is? Okay, let's discuss about DDH, because I'm hoping a question from DDH will come up. So let's discuss different aspects of DDH. The first MCQs that they can ask from DDH is about risk factors and about all these contributing factors. So let's understand few important MCQs in DDH which you have to buy at. There is no other clue for this. See, MCQs in DDH are most common. DDH is more commonly seen in firstborn children. It is more commonly seen in females. It is more commonly seen in fetal malpresentations. It is more commonly seen in breech, and specifically frank breech with knee in extension. It is more common in Western countries and natives than in Indians. The side that is more commonly involved is left, then bilateral, then right. There is 20% chance of bilaterality, and family history is involved. So from this much we know that this is a wrong answer. Right hip is not more commonly involved. It is left hip which is more commonly involved, and I've talked about that in my videos as to why left hip is more commonly involved. Okay. The next thing is easy way of remembering risk factors is the letter F. Firstborn, female gender, foot first presentation, family history positive, foreigner more than Indian, fluid low, and left. This is a trick in which you can remember risk factors of DDH. Okay. Next, let's move on to the tests. So Ashutosh told me that the thing that was written there was wrong. He told Ortolani test is not for dislocatable hip. So let's find out whether Ashutosh is right or wrong. So the tests for DDH are two. There is Barlow's test and Ortolani's test, and many times students get confused with this. So let's understand what Barlow's test is. Look at this animation carefully, which I'll show you next. So here, first we'll demonstrate the Barlow's test. So you hold the hip in knee in extension, and you keep fingers along the thigh, and you adduct. First you adduct, and then you apply pressure using a thumb, and this will dislocate the hip. When you adduct and put pressure in the thumb, it is going to dislocate the hip. Then you abduct and you remove the pressure. This will relocate the hip. This is the Barlow's test. Barlow's test first involves dislocating the hip, and then step 2 is relocating the hip. So that is the Barlow's test. So in Barlow, we are testing for dislocatable hip. In Barlow, we are testing for dislocatable hip, and the step 2, if it is done individually, then it becomes the Ortolani's test. So in Ortolani's test, we are checking whether it is reducible, whether the hip is reducible. Okay, so Ashutosh was correct here when he said that option was wrong. So what is the Barlow's test and what is the Ortolani's test? Barlow's test is when you first do a dislocation by adducting the hip and applying pressure with the thumb, and then relocating. You'll have two clunks, one clunk of dislocation, one clunk of relocation, and that is a test done for dislocatable hip. Please remember this, dislocatable hip. Ortolani's test is to check for reducible hip, where you do abduction test, and with abduction, if there was a dislocation, it will reduce back and you will get the clunk of reduction. Okay, so that is the Ortolani's test. So based on that, we know that this option is also wrong. It is Barlow's test which shows for dislocatable hip, and Barlow's is preferred over Ortolani. Okay, now let's look at what is this Klissick sign. What is the Klissick sign? Okay, so if you can't remember Barlow and Ortolani, normally just remember this animation, that Barlow is bad and better also. Barlow is bad and better because he dislocates the hip. Ortolani is good because he reduces the hip. Now, in older children, you can't do Barlow's or Ortolani's test, so you have to do different tests. So what you do is you check for thigh folds, they'll be asymmetrical. You check for limb shortening, external rotation, and also shortening of limb can be checked by Galeazzi's or Ali's test. I've already told you before, Galeazzi's sign or Ali's sign. Please read up on this. It can be a potential MCQ. Telescopy of the hip is done, where you can see if there is any telescopy that suggests that the hip is dislocated. Trendelenburg test will be positive. Vascular sign of Narath will be positive. Now, in rare cases, I told you in 20% cases, DDH can be bilateral. If there is bilateral DDH, there is only two signs that you can see. One is Klissick sign and another is waddling gait. Only these two signs can be seen in a bilateral DDH. So Klissick sign is seen in bilateral DDH. Okay, so that statement was correct. Now last about investigation. See, in DDH, you cannot do an X-ray because bones are not yet calcified, so you won't be able to see anything. So the investigation of choice for DDH in less than 6 months is to do an ultrasound. And in ultrasound, you will get an image like this. Now, to get the normal value of DDH, you have to draw these alpha and beta angles. I won't go into the detail of that, but mainly alpha and beta angles are done by checking the cartilage and bony covering of acetabulum. And based on that, you have to just remember one statement, that in DDH, alpha angle reduces, beta angle increases. Just remember this much. Alpha angle reduces, beta angle increases in DDH. Okay. So now that you understood all of this, let's go back to the question here. So this statement is wrong because beta angle increases in DDH, alpha angle decreases in DDH. Ortolani test is not done for dislocatable hip, it is done for reducible hip, and Barlow is preferred, and left hip is more common than right hip. So these three options are wrong. So the answer is Klissick sign is seen in bilateral DDH. Is this clear? I hope DDH is covered. Please read a little bit about DDH because it can be a potential topic to be covered. Now, I also predict that there'll be a question from sports injuries being asked because it has been a long time. It's been at least 4 years that they've not asked any question on sports injury. The last question they had asked was, I think, about this terrible triad that they had asked. So now look at this question. A patient comes with a meniscal tear in the right knee for repair. For injury to which of the following zones of meniscus would you consider meniscorrhaphy? Meniscorrhaphy. Is it gray zone, red zone, white plus red zone? Anyone who knows this concept? Shabir says it's gray zone. A, gray zone is what Shabir is saying. Anyone else? Dr. Kanaga says it is red zone. Dr. Kanaga is saying it is red zone. And anyone else would like to pitch in? Come on, last two questions here. Let's have maximum participation for this. Is it gray zone, red zone, or white plus red zone? What is meniscorrhaphy? What is meniscorrhaphy? Is it replacing the meniscus or repairing the meniscus? What does raphy stand for? Anyone who knows what raphy stands for? Repair, correct, yeah. So Shabi says repair, yeah, it is meniscal repair. So when will you think of meniscal repair? When you believe that meniscus has a potential to heal, only then will you go for repair. If you don't feel it can heal, you will then go for replacement. So let's look at what is the blood supply of meniscus. So the meniscus gets its blood supply from a genicular vessel. It comes from a genicular vessel, and most of the blood supply is to the peripheral rim area, and this area is called as the red zone. This area is the red zone. The middle area is the red white zone, and this inward area is the white zone. It is a white zone. So now if you can, after remembering this information, now can you tell me which zone? Periphery vascular, correct? Yeah, Dr. Kanaga is right. Peripheral area is more vascular. So now can you tell me where would you do meniscorrhaphy? Where would you dare to do a repair? Where would you go for replacement? Yes, Dr. Kanaga, you're absolutely right. In the red zone, you will go for repair because good blood supply. If you repair it, maybe it will revascularize and heal. But if there is a white zone injury, then you will go for a replacement. So please remember this concept that meniscorrhaphy is done in the red zone, meniscectomy or excision is done in the white zone. Yes, Soumya, Ashutosh, both of you are correct. Red zone is where you will do a meniscorrhaphy, and the rest of the area you will do a meniscal excision. Okay, so this can be a question asked. Now the last question, and obviously the question has to be from osteoporosis because every year there is a question asked from osteoporosis. So my question here is, what is the standard index used in x-rays to grade osteoporosis? Is it Davage's index, Singh's index, DEXA index, T-score? Come on, last question. Want everyone to answer. Dr. Kanaga says it is T-score. I'll read the question again. Standard index used in x-rays to grade osteoporosis. Read that question very carefully. Dr. Kanaga's answer is T-score. Anyone else with any other answer? Ashutosh also believes it is T-score. Dr. Soumya, Dr. Shabir, Dr. Sakshi, would you like to contribute to the last question of this session? Soumya says it's DEXA. It's DEXA index. Dr. Soumya says it's in DEXA index. Anyone else? Shabir, I've not got your answer yet. What do you think is the answer here? Not D for sure. Okay. Shabir doesn't believe it's D, so he's ruled that out. Sakshi says it's DEXA. Ashutosh says it's B, Singh's index. Okay, Ashutosh is going different route here. He says it's Singh's index. Anyone who agrees with Ashutosh? Shabir, yeah, D is not correct. Okay, so let's rule one thing out. T score is not an index. It is just a measurement with which you look for DEXA scores. Okay, so T score is not the answer. Okay, so the concept here that most of you are getting confused with, and that's why you're answering it as DEXA, is that DEXA is one modality of investigating osteoporosis. In fact, it is the investigation of choice. DEXA is the investigation of choice to test for osteoporosis. But here they've already given which modality. What is the modality they've given? They've given it as X-ray, not DEXA. DEXA is a different scan. X-ray is a different scan. So they are telling you that they've done an X-ray, and in that X-ray they want to grade osteoporosis. Which index should they use? So if you've studied osteoporosis theory, there is one line where there's mentioned that in X-ray you can grade for osteoporosis using an index called as a Singh's index. Called as the Singh's index. So here Ashutosh was right. He was the only one who gave a different answer, but he was right. So always shows you that different does not always mean wrong. Okay, so Singh's index is the answer here. See, if they ask you which is the investigation of choice, then the answer is DEXA. If they ask you in DEXA, how do you measure, then the answer is T score. But here they're asking you that it is an X-ray that is done. How will you grade for osteoporosis? Then the answer becomes Singh's score, Singh's index, Singh's index. Okay, so this is the Singh's index that you see here. Osteoporosis grading on X-ray based on these tensile and compressive marks. Okay, these using this they do. You don't have to go into detail of that. Just remember Singh's index because it can be one of the potential questions that they'll ask you in the exam. Okay, so this was about Singh's index. Please read osteoporosis in detail because they'll ask you questions on that.